Good day, everyone. I'm Neil Love from Research to Practice, and welcome to Striving for Consensus, optimizing the multidisciplinary management of non-melanoma skin cancers. Today, we'll be focusing on squamous cell carcinoma and basal cell. We have a great faculty today, Dr. Nikhil I Khushalani from the Moffitt Cancer Center in Tampa, Florida, Dr. Soo Park from the UC San Diego Moores Cancer Center in San Diego, California, Dr. Vishal Patel from the George Washington University School of Medicine and Health Sciences in Washington, D.C., and Dr. Evan Wuthrick from the Moffitt Cancer Center also in Tampa, Florida. As in all of our programs, we will be discussing the use of unapproved agents and regimens, so please consult the package inserts for various products for more information. Here's where we're heading today. Nikhil will talk about some really exciting advances that are going on in squamous cell, particularly from the medical oncology perspective. Dr. Wuthrick will talk about radiation therapy, as how it fits in terms of multidisciplinary care. Dr. Park will then review issues related to systemic therapy, but particularly as for basal cell cancer. And we'll finish up with Dr. Patel talking about dermatologic perspectives on the management of these patients with these cancers. Before we get started, I just want to take a breath a little bit and, thinking about our primary target audience that I described being the general medical oncologists in the community. I'm curious if you have any thoughts or perceptions about, maybe myths or misperceptions that they might have, or areas that maybe we should focus on today that maybe they're not as aware of, newer things, newer developments, dermatologic issues. Evan, any thoughts, again, in terms of things that we maybe ought to emphasize today that maybe medical oncologists are not aware of?
Well, I think one of the basic things is that because for most patients, especially those that are not immunocompromised, the treatment of early stage basal and squamous cell carcinomas, there are a lot of options. So a patient can obviously certainly have surgery, whether that be a local excision or a micrographic surgery, but it's really in determining what the best combination of efficiency and a cosmetic outcome. That's really it. So if a patient doesn't want to have a surgery on their face, or for whatever reason, whatever the area is, radiation therapy still remains a really good alternative. Still, all of the large, big retrospective series have greater than 95% long-term local controls for radiation therapy series. So the patient doesn't really have to feel like they're sacrificing much on the local control, tumor control standpoint to use a radiation therapy option. What they're really sacrificing usually is some time, because surgery is a much more efficient, you come in with the tumor, you leave without it. And radiation therapy usually takes multiple fractions. But that, depending on what the person's situation is in life, that might be a good trade-off. So it's kind of ends up being a game of would you rather. What would you rather do to solve this problem? And for many patients, and for younger patients in particular, that would you rather usually comes down with surgery. But as circumstances change, sometimes the use of radiation therapy increases. The other thing is that some radiation oncology clinics are starting to use much more hypofractionated courses of radiation therapy, meaning that there's less total doses that are given in order to achieve the same outcome. Sometimes that comes at the cost a little bit of cosmetic outcome long term, but if that's not the most important goal, or if the area that's being treated is relatively small, then that's fine. We even have at Moffitt a surface brachytherapy program where we put a radioactive material have an applicator, and the radioactive material sits right next to the tumor. And over the course of a couple of minutes, that radioactive source is decaying and it's shooting off gamma rays, and those gamma rays are causing the same DNA damage that you would have with any other type of radiation therapy. And these regimens are often done twice a week and are done over 8 or 10 fractions. So it's less difficult for many patients to get back and forth for a regimen like that.
Vishal, you had a comment?
Yeah, I just want to echo Evan's points, and I think for our audience, especially as medical oncologists, we sometimes, especially in the U.S., have become such a procedurally oriented medical field. And so surgery always gets the first nod. But our patients are 60, 70 years of age. You can treat 20-year-olds, 30-year-olds with skin cancers. You can treat 90 and 100-year-olds with skin cancer. And radiation is thought of as salvage or adjuvant or whatnot, to Evan's point. completely underutilized for a vast number of the patients. And so I echo Evan's points that I think even dermatologists, we don't think about how great we can utilize. And I don't know if Evan, if you've heard about this, but I'm pretty excited. I've heard of in Australia and Germany, topical radioisotopes that maybe come into the US. I think that's going to be a really great option where we can combine these expertise. But if you're not thinking like that or aware of that, of the radiation oncologist or what the dermatologist can or can't do in the future, depending on the treatment, it hamstrings what you can offer to the patient now.
Nikhil, I'm sure you go out and give talks all the time to community-based general medical oncology reviewing these topics. What are some of the things in your mind that you want to try to get across that you feel are messages in general that are so important to communicate?
No, I think Evan and Vishal have already covered the bulk of that. To me, we need to impress upon everyone that managing skin cancer now is truly multidisciplinary, but at the same time, I would just caution everyone that anti-PD-1 immune checkpoint inhibition is not the answer for every single patient. And these patients need to be chosen carefully. We do see where sometimes there may be, I use the term unregulated use of an anti-PD-1 because we know it actually works in several of the diseases that we treat, but there may not be necessarily an indication for it. And these drugs are not without trivial toxicity. We do have some chronic long-term toxicities, and in the rare case, some devastating toxicities, particularly endocrine or myocarditis associated with them. So I think as far as possible, we should try to stay within the recommended guidelines and feed off each other's expertise to say when is the right time to introduce systemic therapy for these patients. I think the other important thing is prevention. While, we are seeing the age spectrum entirely from 30-year-olds. This week I had somebody in my clinic in their mid-30s with metastatic cutaneous squamous cell carcinoma.
Wow.
That's an unusual occurrence. And we excluded immunosuppression for that individual, and that individual will be starting systemic immunotherapy shortly. But the vast majority of these patients are typically in their 70s and 80s, and we have to respect their additional comorbidities and also put that into perspective in terms of their overall outcome and longevity.
So, Sue, I'm interested in your perspective. We're just about ready to go out to San Francisco for the annual GU Cancer Symposium. We're doing a couple of programs out there, but one of them is on urothelial bladder cancer. And, now in bladder cancer, they have a very effective systemic therapy. They're combining an ADC and enfortumab vedotin plus a checkpoint inhibitor, pembrolizumab, seeing very excellent responses. Now we're talking about bladder sparing, maybe people not having to have cystectomy because of such effective. So I think, the idea of, oncologists being involved with localized disease is happening across oncology. But again, I'm just kind of curious what your thoughts are about what's going on in the community setting right now as that message, particularly related, again, to the issue of the oncologist being involved earlier. Do you think that message has gotten out?
I think that message is getting out, but we can obviously improve on that. I actually treat bladder cancer over at the VA, and so I know exactly what you're talking about, the use of Periop, enfortumab, and Pembro. And I think our field is also moving that direction. We recognize how powerful immunotherapy is for our patients. And so in some instances, for some of our patients, that's all we're using. So there's a lot of interesting questions that are starting to come up. Do we even need surgery? Do we even need radiation? And as a medical oncologist, at an academic center, I really like to try to, come up with ideas and push the envelope. And so, I often hear Vishal say, I only am a medical oncologist on TV. And so I like to take that and say, I only play a dermatologist on TV. But I really feel like being in this field, being exposed with other team members has really also made me more focused on, systemic therapies in the earlier setting. And I really think prevention is really important. And I'm trying to, possibly introduce systemic therapy in that realm as well. And so I'm just really excited. And I think more education is always great.
So I think we're going to get into a lot of things that you just brought up. But I want to dive into Nikhil's talk because, again, I can tell you there are a lot of things in here that most oncologists are not aware of. So I'm really looking forward to being able to share this. So, Nikhil, take it away.
Thank you again, Neil. So this is a speed dating session on squamous cell carcinoma where I'm going to try and cover a lot in a finite period of time, but I'd like to leave a lot of room for discussion. So we'll try to go over some of the didactic data slides fairly quickly, but then really open this up to how we truly manage our patients. So when you review the sheer magnitude of the total number of keratinocytic carcinomas that we see, and keratinocytic is a common term, including both basal cell carcinoma as well as cutaneous squamous cell carcinoma, you have to look into claims databases to understand how many actually occur per year in the United States. And at rough estimates, it's about 5.5 million cases per year in the U.S. Annually. So that is a sheer high volume. But that sort of almost makes it incumbent on us to really identify which one of these are truly bad players, because the vast majority of these are treated by Dr. Patel, by surgeons, by other dermatologists. So there are very specific features, both patient-related as well as pathology-related, that can potentially predict the risk of recurrence or death in cutaneous squamous cell carcinoma. And this was one of the older attempts at trying to stratify this, but importantly, this has also led to the development of staging systems. So this was a 10-year single institution retrospective look at all of their cases, and this essentially was about almost 1,000 patients, about 1,800 tumors. And what they found was they identified specific risk factors, so larger tumors, greater than 2 centimeters, poorly differentiated, deeper tumors, specific anatomic locations, and very importantly, the presence of perineural invasion that helped to identify higher risk patients, both for development of nodal metastases as well as disease-specific or overall mortality. And what you see on the bottom right-hand side is specifically a nerve that is involved with cutaneous squamous cell carcinoma. And in this particular study, local recurrence was seen in about 5% of cases, nodal metastases in about 4%, and a small percentage, just 2% of patients succumbed to this disease. But when you look at what your denominator is in terms of the total incidence of these cancers, that's actually quite a substantial number. So it's important to recognize that we need to try and intervene sooner. So further, how do you actually define or stage these patients? And a lot of these patients come to me after they've already had their surgery done, or now, of course, in the multidisciplinary setting when they have macroscopic nodal disease, we can evaluate them for neoadjuvant therapy. And our traditional staging system has always been the AJCC TNM staging system, but there were a lot of deficiencies in the earlier version of TNM, which is the previous AJCC 7, back in 2010. That since has been updated exclusively for cutaneous squamous cell carcinoma of the head and neck. But when you look at the original staging system, the T2 tumors essentially occupied most of the patients who went on to develop nodal or distant metastases. But the Brigham and Women's Hospital staging system came into being around 2013, where they specifically looked at, again, as I explained to our fellows, the 3Ds and perineural invasion. So tumor diameter, poorly differentiated tumor, and tumor depth beyond subcutaneous fat. And each one of these gives a point. And if you have all four, these are T3 tumors. And what you can see is in their validation, those with 2 or higher risk factors, while they account only for about 6% of all squamous cell cancers, those are the bad players. Those are the ones that have 70% of nodal metastases and almost 80% or higher of deaths that are related to this disease. So I think that's an important clinical pearl in terms of staging when you see these patients at an earlier time point. And this was further validation that was only recently published, where every incremental increase in the number of risk factors, exactly the same 4 risk factors that I highlighted earlier, increase the risk of local recurrence, nodal metastases, distant metastases, and specifically disease-specific death. I think disease-specific death becomes really important in squamous cell because most of these patients, the average age is 75 or higher, and therefore the likelihood of them succumbing to another life event, whether it's a cardiovascular event, it is a CNS event, a pulmonary event, potentially maybe higher than related to death from squamous cell carcinoma. So I think we need to take that into account when we manage these patients as well. So how do we truly then try to define this high-risk approach? Should we try to take a personalized approach? And there are now several models that are available out there The one on the left, on the top left, was from Rotterdam, and they came up with a model that looked at both clinical as well as pathologic characteristics to try and predict what the risk of metastases at 1 year, 3 years, and 5 years was. This is an online calculator tool. The one in the middle was through the SCOUT consortium and extending their findings across multiple centers, but that also looked at the type of surgery that was incorporated in the management for these patients, and then trying to assess what the risk was for these patients. And then finally, we also have a gene expression profile that is done on the primary tumor, again, trying to estimate what the risk of nodal metastases is. And again, I think some form of combination of these various calculators may help us streamline at a personalized level how we can approach this for patients. I wanted to spend a minute just discussing, unfortunately, what do patients in cutaneous squamous cell succumb to? What is their pattern of disease-specific death? And in most cancers, we typically would say patients succumb to metastatic disease. We didn't have great data for CSCC, small studies that had been done previously. In fact, the princely sum of 61 patients in 2 small studies previously. But this was a much larger effort coordinated by the really good group in Boston, where they looked at 12 centers, international, 10 in the U.S., 1 in Spain, 1 in Brazil, over 14,000 patients, and identified in that 304 patients, so 2.1%, almost identical to the original Brigham and Women's slide that I showed you earlier, succumbed to cutaneous squamous cell carcinoma. And in these, 45% had local recurrence, and additionally, 86% had some form of metastases, either nodal, in transit, or distant. But what was striking was 2/3 of the patient died from local, regional, uncontrolled progression, whereas 1/3 of them succumbed to distant metastatic disease, most typically pulmonary or bony metastases. And what you see on the right side Kaplan-Meier curves is those patients who are diagnosed with synchronous metastases in the beginning tend to have a worse prognosis compared to those who develop it metachronous over a period of time. That means they have their CSCC identified and treated first, and then down the road they'll end up developing metastases. Those patients have a better prognosis as opposed to simultaneous detection for this. Just quickly switching gears to neoadjuvant, and I wanted people to really take home, how do we actually truly define neoadjuvant? And in clinical trials, in our interpretation in Multidisciplinary Tumor Board here, we are very specific with how we define this, and that is highlighted here. The administration of systemic therapy prior to surgery in patients with accessible resectable disease, most importantly with a plan to carry out resection after a finite period of time or a finite number of cycles of treatment. And you can assess that either radiographically or clinically. It should not be applied to individuals who have unresectable disease, get treated with systemic therapy, and then have an operation. That's not true neoadjuvant therapy in the true sense of the word. As many of you are familiar with cemiplimab, the first anti-PD-1 agent to be approved for management of advanced cutaneous squamous cell carcinoma. This was tested in a multi-institutional study for neoadjuvant therapy, patients with resectable stage 2 through 4 CSCC. They received 4 doses of cemiplimab prior to surgery and then went on to undergoing curative attempt surgery. And the primary endpoint of this trial was pathologic complete response. A lot of this terminology and life cycle was borrowed from what we had already done in melanoma previously. And very impressively, just those 4 doses of cemiplimab elicited a high path CR rate of 51%. And when you add the major path responses, that is less than 10% viable tumor at the surgical specimen, that went up to about 63 to 64%. But what I wanted to highlight here is the radiographic response did not always correlate to pathologic response. So, for example, we had 6% of patients in this study that had a radiographic RECIST-defined complete response, but we had 50% pathologic complete response. So radiographs will often underestimate the extent of therapeutic benefit for these patients. What was really important in the longer-term follow-up for these patients, the 24-month event-free survival was a remarkable 84% at 2 years, and most importantly, the 40 patients who achieved a pathologic complete response on that study, at the last look, none of them had relapsed. So it is potential that pathologic CR is actually a surrogate marker for disease control in this disease. So if one drug is good, should we try two drugs? And this was the neoadjuvant MATISSE trial that randomized patients to either nivolumab, anti-PD-1 therapy, single agent, 2 doses, 14 days apart, or adding ipilimumab at low dose, 1 milligram per kilogram to nivolumab prior to the first cycle in arm B. The trial originally planned to accrue 40 patients, 20 in each arm, but as they conducted the trial, they recognized that some patients decided not to undergo surgery because they were having very nice responses. So they had to extend it and add 10 additional patients for a total of 50 patients so that they could get their appropriate numbers as they had planned. The pathologic response rate, the major path response rate here, was 50% with combination therapy and 45% with nivolumab monotherapy. And what you see on the bottom right, Kaplan-Meier curves, very high disease control rate in those patients who achieved a major pathologic response. Essentially, the DSS, disease-specific death, was essentially negligible at 2 years, with all of those patients still alive and not succumbing to cutaneous squamous cell carcinoma. So briefly for this summation, neoadjuvant anti-PD-1 immune checkpoint blockade clearly has the power to result in very high path-CR and major pathologic response rates for resectable disease. And in my mind, at least, path complete response may potentially be a surrogate for improved outcome in this disease as well. Neil, you have a question.
Yeah, so before we go on, just to sort of clarify a little bit more about sort of what's going on right now, and I'll turn to Sue. You know, one question we get all the time, it's a huge issue. Maybe we'll get into it later, but I'm going to bring it up right now because we're talking about neoadjuvant therapy, is the issue of cell-free DNA MRD assays. One that's commonly used is a Signatera assay, used a lot in colon cancer, but now we're seeing it through all solid tumors. Is there any work going on with cell-free DNA in this localized disease setting, Sue?
Yeah, that's a great question. I do use it in, colon cancer and a lot more Merkel cell carcinoma. I think there are some groups that are trying to look at it in cutaneous squamous cell carcinoma. But I think one of the problems is that, cutaneous squamous cell carcinoma is not a highly shedding tumor. And so that may sometimes limit the applicability of a ctDNA assay. But I think it's certainly worth looking into.
And Evan, also, another issue that comes up all the time, and really this started with breast cancer a long, long time ago, and we saw it get involved with many other tumors in the adjuvant situation, is kind of what I would call a numeracy. This is going to be a theme I want to bring out to you. I don't know if you're familiar, but quite a few years ago, there was actually an online nomogram called Adjuvant Online in breast cancer, where it's kind of like the models that Nikhil was just putting out, but you would put in different numbers, and it would actually do a plot and show you the best estimate they had based on the data they have and what the risk was of recurrence and death, and then how that was affected by various types of treatment. In this case, it's chemotherapy, hormonal therapy of breast cancer. But I'm curious whether or not, Evan, you think that culture of numeracy exists as it relates, again, to these cancers here. We saw the models that Nikhil talked about, but typically are patients getting numbers to say, this is what your risk of recurrence is, and if we give you whatever type of therapy, here's where it's going to come down to. Here's the risk of the treatment, and if it's chemotherapy, you potentially even lethal complications. So just kind of curious, Evan, whether you think numeracy has sort of entered the stage with localized squamous cell and basal cell.
Well, I think one of the, big challenges for any oncologist is in the first, as you're starting to meet, a new consult patient for the first time, is trying to meet them where they're at and trying to figure out how they want information presented to them, because we all know patients, engineers or whatever, who want to know down to the 10th percentage decimal point what the chances, your best estimate for what the chances of these various outcomes being. as if you're kind of spitting it into a computer model. And then there are other patients who their only question they have for you is, what would you do if you were me? Or what would you do if this was your father being treated or something like that? And so I think, one of the jobs of the oncologist is to figure out where in that spectrum each patient is and try to meet them at that place. For me, if I can sense that the patient wants great detail, I am quite comfortable with giving estimates from the nomograms that, Dr. Khushalani that Nikhil just discussed with us, because I think that is our best estimate of what the risk of a squamous cell carcinoma is. And we are blessed to have a lot of these tools that we can, use. I myself use that one, an app that has the RI SCC calculator on it. It's, I'm not saying that that's the perfect God's truth, but it is a pretty good way to get to the estimate of what the patient's risk of recurrence is, and it breaks it down quite nicely. So I think that for the patient who wants to know it and who you get a sense has some numeracy, that giving these numbers and then saying, hey, and in previous studies, we've noticed that radiation therapy can reduce that risk of local recurrence by 2/3 or 3/4 or whatever the answer is, and then say, and now we have to decide whether all of what you're going to have to go through with the radiation therapy, whether that's worth it or not. And depending on where that person is in their life, their goals, how easy it is for them to travel, a whole number of things. There may be two different patients presented with the same numbers, and one says, yes, let's do it, absolutely. And the other says, no, I don't, I think I'd like to, be on a close surveillance program and not do postoperative radiation or something like that. So I think that that's one of the beauties of the art of medicine, is trying to meet the patient where they're at with that kind of thing.
No, I think your thoughts are just so on target. We talk about this all the time. Sometimes we bring up the idea, well, suppose the patient is a medical oncologist, so they totally understand these numbers. They want more from you, But again, as you say, we've done lots of surveys of patients. We know there's some, as you say, some who don't want to risk toxicity even for a great benefit, and some who are want to be treated with everything. I'm also curious, Vishal, where surgeons fit in. Are these general surgeons? What type of surgeons are working with these patients? The interface between the dermatologists and the surgeons, and how well the surgeons are tuned into, for example, neoadjuvant therapy.
That's a great question. We're right at the time when that is evolving now. But I wanted to add one comment about those numbers, because I think it's also just gives us some light, is we've made some progress with these nomograms to be able to quantify the risk. But as a field, we don't have much equipoise or agreement on how to act based on a certain number. Is a 5% or a 10% or a 20% risk the threshold to intervene? And intervene with what? Radiation, systemic therapy, more surgery, Mohs versus regular surgery. That's a big challenge, let alone, as Evan pointed out, I have patients who 3% is something they can't sleep at night, and others that say 30%, 70% cure rate sounds pretty good to me. And so when we translate that to surgical kind of therapy, there's a challenge here, not only for patients, but also when we talk with our providers and our colleagues. Skin cancer is managed by all different types of surgeons. The Mohs surgery field has really evolved just because, as Nikhil said, 5+ million cases a year. There's so many skin cancers of all different types of presentations coming to dermatologists and Mohs surgeons for treatment. And Mohs surgeons have become more and more adept of doing in-office setting, more serious, aggressive, deeper surgeries, and really remarkable reconstructions that historically we would do with a plastic surgeon in the operating room and would require a lot of planning. And we've shown now with literature good outcomes for recurrence risk reduction and micrographic surgery as being the optimal way to do that. But in other places, head and neck surgery, surgeons are doing that. The challenge is disseminating the information, what Nikhil said about neoadjuvant therapy, systemic therapy. We'll discuss about adjuvant or even adjuvant radiation amongst the different fields, and being on the same page, because surgeons also have their own experience and their views. And to Nikhil's point, these are not trivial. Surgery is not trivial either. My head and neck surgeons, I have mentors who are Mohs surgeons who'd say, There's no skin cancer that's not surgically resectable, and I can beautifully reconstruct anything with the forehead interpolated, flap or a cheek to nose and a cartilage. But because you can, should we? And I think that's where now we have to start to get into discussing is should we?
So before we get into Nikhil's case, I'll just comment on something we've done a lot of, and I'm going to do today, which is you are highlighting a really important point, Vishal, which is, it's one thing to try to give an estimate of risk of recurrence, but then it's another to try to get an accurate estimate on the risk of benefit or the likelihood of benefit, and particularly the absolute numbers of benefit. And one of the ways people can say, well, we don't have a perfect model, we don't have a perfect data, et cetera. One of the ways we've dealt with this, and I'm going to do this with you today, and we actually had a poster. We do a lot of posters in our surveys. We had one at the San Antonio breast cancer meeting a few years ago. We were talking about adjuvant therapy of HER2-positive breast cancer. There was a lot of controversy at that time about what to do in different situations. And we did a survey of, we took 20 clinical investigators in breast cancer. We just said, here's the situation. You have a patient who has this size tumor, nodes, et cetera, and the patient would like numbers and is asking you, what's your best estimate of the risk of relapse and the risk of relapse with treatment, or the absolute benefit? And what we saw was very narrow answers. The investigators were they kind of were all coming off the same databases, but then when we got out to the community, they weren't as tied into the data, so their estimates were not, were much more wide. And we'll get into some situations. I'm curious, we might have perfect data, but people are going to be asking you, what is your best estimate of my risk of relapse, and how do you think this therapy is going to affect it numerically? That is the benefit of therapy in many situations, that changing a number. Well, let's get into some cases here. Nikhil, what happened with this 72-year-old man?
Sure. Just actually, before I get to the case, just to add on to Vishal's point, is the heterogeneity of the providers who actually see the patient first. I think education, as you pointed out, Neil, becomes so important. So I've actually now attended a head and neck meeting for education. I've attended the American Academy of Dermatology meeting to give a talk on neoadjuvant therapy, and I've even attended a Mohs surgery meeting. And these are meetings that a medical oncologist traditionally would never go to in the past. But I think that highlights our close interaction now with other disciplines as well.
The other potential target are patients themselves. I mean, a lot of patients are there are advocacy groups out there, et cetera. And so that's another group to be educated. A lot of times people walk in and they're going to educate their doctor. Anyhow, Let's hear about the 72-year-old man.
So here's a 72-year-old male native to Florida. I intentionally put native to Florida because when I first moved here 10 years ago, almost every patient that I saw came from somewhere else, whether it's the Northeast, the Upper Midwest. And I'm like, who's here? Who was here before all of the transplants came here? And then as you stay here long enough, you meet plenty of people who grew up in this area. So obviously,
Nikhil, isn't that code for extreme amounts of sun damage?
There you go. I added that on to
it means you had a good time.
There you go. Long history of surfing and sailing, no other major medical issues, and obviously a long history of multiple actinic keratoses on the head, neck, and extremities. So he had a 3-centimeter erythematous lesion, right anterior thigh skin, about 18 months ago, underwent wide resection. Final path was a poorly differentiated squamous cell carcinoma, 3.4 centimeters with perineural invasion. So for those of you who are paying attention to the first part of my talk, this has 3 high-risk factors. Tumor diameter, differentiation, and perineural invasion. So that's 3 factors, makes it a Brigham and Women T2B tumor, so potentially high-risk tumor for recurrence. Baseline PET-CT, no evidence of metastases, and he underwent adjuvant radiation to the operative site, associated toxicity that recovered, did well. And then about 18 months later, which is the present day, he now develops a right inguinal swelling, palpable mass of, again, 3 centimeters, mobile, no evidence of in-transit recurrence. We do a fine needle aspirate from the right groin node. Lo and behold, it is squamous cell carcinoma. You see the fused axial image of the PET-CT on the bottom right here, an FDG avid node, possibly a second smaller node just adjacent to it. And we discuss treatment options with this patient. So with those options, he decides he's going to undergo right inguinal lymph node dissection. And at final pathology, 14 nodes are retrieved, 3 are involved with metastatic spread. The largest is 3.1 centimeter with evidence of extracapsular extension. He has recovered well. He's now in your medical oncology office, says, Doc, what next? So what should his next option be? You can see these options here. Should he now get adjuvant radiotherapy to the groin? Should he get this with carboplatin given weekly, similar to what was done in the TROG trial? Should we just directly go to immunotherapy, adjuvant cemiplimab for a year? Should we do both of the above? So adjuvant radiation followed by adjuvant cemiplimab for a year? Or should we say surgery was adequate and we should just observe him? So thoughts on this. Evan, what do you think? Is this a candidate for postoperative radiotherapy?
Yeah, this is a candidate for postoperative radiation therapy because the highest risk factors for recurrence in the draining nodal basin after surgery are size of the largest lymph node and number of lymph nodes and extracapsular extension. All of those are independent. And this person has all 3 of those, had multiple lymph nodes and a relatively large lymph node, or at least medium-sized lymph node, and had extracapsular extension. So because of that, I think that 1 and 4 are potentially acceptable answers.
Would you give chemotherapy?
So no. So the TROG study basically was a negative study. Now, it had some problems with it because they may not have used the ideal dose of carboplatin, and they may not have chosen a high enough risk group. But in general, I think the answer to this question is still no. And the main problem with adjuvant radiation therapy is that this patient probably would have, after a node dissection and a course of adjuvant radiation therapy to the groin and pelvic lymph nodes, about a 20% risk of significant lymphedema. And so that is the major downside of this plan. One important thing to note for the audience is that it's been pretty well tracked that risk of lymphedema does also correlate with the patient's BMI. So heavier patients have a higher risk of lymphedema after surgery radiation. Patients who are of normal BMI have a less chance of that. But that is still a major downside to that plan.
Evan, can I ask you a question about that risk? And Nikhil, I for our audience here, a leg squamous. So when we usually do these kind of education programs, we're talking about cases. We often are talking about head and neck. We talk about local regional disease, and we're seeing pictures of neck mets, neck masses, or parotid. And so this is striking to me just based on the presentation, because it's not the typical thing that we think of, and that's a good take-home point for our audience. But also, is that risk, Evan? Just I'm looking at this. This is like a melanoma presentation where I think about that from that kind of standpoint of just the anatomic location, but the risk, the head and neck with radiation and lymphedema, because that's not discussed in our tumor board as much. When you brought that up, I didn't even think about that.
Yeah, so that's the point. That was an important point for inguinal lymph nodes, because the risk is about, like I said, about 20%. In the axilla, that risk of axillary dissection followed by radiation therapy, the risk of long-term lymphedema that's really significant in the patient is about 10%. Mm-hmm. And then it's about 1 or 2% in the neck. Yeah. And sometimes that'll be like a submental lymphedema situation. So that's
specifically with surgery and radiation.
Yes, surgery followed by radiation therapy. Surgery alone, those numbers are usually maybe about half of that.
And radiation alone?
Very rarely. You really need to treat the bilateral draining nodal stations, which we almost never do in skin cancer, in order to get that.
I was going to ask Sue not only how she would manage the patient and whether she would use cemiplimab, but also what numbers, if the patient wanted numbers, what numbers would you give the patient of the risk of recurrence and death with just radiation alone or with radiation plus cemiplimab?
For this patient, I think there's maybe 3 potential treatment options you could consider, because the patient did have a recurrence at the nodes. I would definitely give adjuvant radiotherapy, but because on the surgical pathology, they have at least 1 node that has ECE, and that node is 3.1 centimeters. But in addition, they already have 3 nodes that are involved. I would also offer adjuvant cemiplimab after adjuvant radiation. But, not all patients want adjuvant cemiplimab, and that's okay. So I think depending on what the patient wants and their tolerance for risk, 1 or 4 is reasonable. There's a great disease-free survival benefit with adjuvant cemiplimab. I also sometimes will consider number 3, just bypassing radiation. I know that's not really based on any data, but we have some patients that have gotten radiation before. They can't get radiation or again, or sometimes I think their risk is really high. They recurred very, very shortly after radiation. And so sometimes, after shared decision making, we'll consider number 3, but that's not really based on any data, just basically clinical.
So, Nikhil, I'm curious what actually happened with the patient, what kind of discussion you had with the patient. And again, I don't know if this patient asked you or not, but if they had, what the risk of recurrence would be with or without cemiplimab, assuming they would got radiation therapy. What number would you give a patient who wanted that?
So based on the time lapse of this patient in terms of the original presentation, high-risk disease, and clearly high-risk disease in the nodal basin right now, I would anticipate that this patient probably has a distant recurrence or the development of distant metastases of somewhere between 25 to 30% over the next 5 years. Now, I have not typed that into the RISCC calculator, but this is, I would say, more based on experience of seeing these patients. And I would be really curious to see what if I typed all these numbers in and what would the likelihood of relapse be for that patient. He's 72. He doesn't have any other major medical comorbidities and otherwise very fit. So I would definitely agree with Dr. Wuthrick that adjuvant radiotherapy is appropriate, but based on the results now of the CPO study, which we'll get into in just a couple of minutes, I think this patient meets criteria to receive adjuvant cemiplimab to potentially, in that study, the hazard ratio for DFS was a remarkable 68% or 67% in that range. So significant reduction in the risk of recurrence for that patient. What we don't know is that's still early data. We don't know whether that translates into overall survivorship. And certainly long-term follow-up of the CPO study will tell us that. I think people have to also view that in the context of a lot of our melanoma adjuvant trials, admittedly two entirely different diseases. But outside of high-dose ipilimumab, there's been no single agent that has improved overall survival in adjuvant melanoma therapeutics. So all of the anti-PD-1 agents improve RFS, but not OS. And people argue, could that be because their salvage therapy in the metastatic setting is so good?
So before Vishal comments, I just want to push back on one more thing, just to clarify, because again,
Sure.
This comes up all the time. Basically, you're talking about using the hazard rate from the trial, which was like 0.32, on a risk that you estimate 25, 35%. Maybe it's not exactly that, but in that ballpark. So how would that translate to absolute benefit, the chance that the person's going to avoid recurrence by taking cemiplimab, roughly?
So I think your chances in terms of when you look at everything as a whole, I would say an absolute improvement of maybe about 18%. You're going from about a 35% risk and, cutting that down by about 68%. But when you look at absolute numbers, it would probably make that absolute number about half of what we are. But at the same time, patients will ask very astutely, well, what's my chance of toxicity with this? What is the likelihood that I will be able to get the entire 1 year of therapy? And when you start talking to patients about 1 year of adjuvant treatment, you can immediately see many of them balking at that and saying that means every 3 weeks or every 6 weeks, depending on what schedule you use. In the trial, it was every 3 weeks for the first 12 weeks and then every 6 weeks for the remainder of 9 months of therapy. So I think that becomes important to understand.
I just want to point out that an absolute benefit of 18% in the adjuvant setting is a lot when you look across oncology. And people, obviously you have to factor in toxicity, which actually compared to chemo, which is used a lot as adjuvant therapy, is much less. But, many cancers, particularly, for example, breast, people are treated where the absolute benefit is, 5% or 10%. So I guess my question also is going to be, as we go along today, do we need to rethink who we're treating? When you have that high of a hazard rate, you start thinking, well, the absolute benefit's so great, maybe more people at lower risk. Whether you can access another issue. Vishal, you had a point?
Yeah, along those lines, I wanted to make two comments and maybe push back and kind of, especially for our audience, to think about this critically. So first, Nikhil, the calculations of the 35%, when this trial was designed, we utilized, and especially a case like this that has the 3 lymph node features, we could pull that from TROG, Sandro, Presidio. Subsequent sub-analyses have shown that 30 to 40%. And so that We don't have that for all of the risk factors that well, but we always think it's around that 40% range for which this trial was done. But an important thing, I think, and Nikhil, we use that nomogram, but I know Anoki and Emily would remind me, because I've used the nomogram, that once the recurrence has occurred, the nomogram kind of falls off a little bit in terms of being predictive. So for our audience, it's accurate for primary tumors. And yes, we like to use it, as Nikhil says, put it in and give us a sense to have more data. But the design is for primary tumors, so this being a regional recurrence makes that challenging to hear. But what I wanted to push was, what about observation? We skipped over that. I agree with all the colleagues. This is a radiation. We would recommend that. This risk is high. But that does not mean, in my mind, that observation, especially if a complete margin analysis surgery and the entire margin was valued, that would bump up our confidence of a negative margin, depending on how that resection was done with the pathological evaluation of the lymph node dissection and whatnot. But this risk of recurrence means there's still the plurality of patients that are not potentially going to recur. And if they did, is the patient, and that's sometimes what we get asked, is what if I don't do anything, and if it does come back? And there is an argument to be made. Devils take the opposing stance that, well, we can rely on the immunotherapy response rates and utilize it then. And so I'm not advocating for that. I think the CPOS trials, as you said, Neil, are as good as it gets, if not the best in the adjuvant setting across solid tumors, but would not be unreasonable if somebody decided to do observation after a discussion. If a community practice doctor said, I'm going to hold my hands and see if the cancer comes back. What do you guys think?
I think, Vishal, you make very astute points. I mean, this is where the art of medicine comes up, and sort of laying out these options. And these adjuvant discussions, I will tell you, are becoming more and more involved with patients. Mm-hmm. And it's a little different in melanoma, because in melanoma, the other big disease that we treat, one of the biggest problems with the recurrence patterns is liver metastases and brain metastases, both of which can be devastating.
But just one final point. I was curious about when this patient originally presented, and had the 3.5 centimeter lesion, what kind of risk of recurrence you would give with and without treatment. But we can get into that later, maybe after we talk about the data. But let's continue then.
So to continue in terms of the discussion that we just had, as Dr. Wuthrick very astutely pointed out, there has been data that suggests the number of involved metastatic nodes following a lymph node dissection is clearly linked to relapse-free as well as distant or disease-specific survival. And anything that's greater than one involved lymph node is clearly a higher risk feature, as was seen in this retrospective analysis from 3 centers in the Netherlands. And immunosuppressed patients did worse as well. And we also briefly touched on the TROG trial, where patients with perceived high-risk CSCC were randomized to receiving adjuvant radiotherapy with or without the addition of weekly carboplatin. And I'll remind our viewers and audience that about 2/3 of these patients had lymph node metastases. And for those of you who are seeing the slides, you can see virtually no difference between the two Kaplan-Meier survival curves. There was no benefit in that trial to the addition of chemotherapy. So this, in its sense, was a negative study. But then, as Vishal pointed out, and I think it sounds like they've all seen my slides even before I presented them, because Vishal pointed out that there was a post hoc analysis from TROG, and this clearly identified 2 specific features to qualify as a high-risk subgroup. This was extranodal extension and a nodal size that was greater than 22 millimeters. And those patients, as you can see, had a 5-year disease-free survival of only 56%. So the vast majority of these patients, their disease came back, and many of them even succumbed to this. And when you factor in the T-staging in association with these patients did even worse as compared to those who had nodal metastases from an unknown primary origin. So this specific high-risk subgroup was the basis of the adjuvant cemiplimab trial that was published last year in 2025 in the New England Journal of Medicine, where we utilized definitions derived from the TROG post-analysis study, specifically looking at high-risk nodal features, extracapsular extension, and one node at least greater than 20 millimeters, or 3 or more involved nodes. And our patient that I presented actually met both of those criteria. or there were very specific non-nodal criteria, including in-transit disease, clinical perineural invasion. I think that's important. Clinical or radiographic involvement of named nerves, not simply perineural invasion under the microscope, and then certainly additional features as well. And these patients went on to receive surgery, postoperative radiotherapy, and then a randomization between a year of cemiplimab versus a year of placebo, with the primary endpoint being disease-free survival. And as you can clearly see here, as mentioned by Dr. Love earlier, a very noticeable difference in DFS between the two arms. The disease-free survival was significantly superior for cemiplimab compared to placebo, with a hazard ratio of 0.32, suggesting a 68% improvement with cemiplimab for these patients. And this was simultaneously published in the New England Journal, and in October last year, cemiplimab was approved by the United States FDA for adjuvant treatment of high-risk resected CSCC. So this, going back to our patient, he certainly met criteria to receive this drug, and so it'd be very appropriate, as option D. But as many of us also during the course of that discussion, some of the other approaches, I think, would be very reasonable as well. But at the same meeting last year at ASCO 2025, we heard results from Keynote 630, which was adjuvant pembrolizumab versus placebo, similar type of patient population. But they halted their study early because an interim analysis failed to reveal superiority for pembrolizumab compared to placebo in that trial. And as you can see, the hazard ratio here was 0.76 with a p-value of 0.07, which did not cross their pre-specified boundary of 0.016, and therefore this was unfortunately a negative study. So we always ask the question, in our groups now, why was Keynote 630 a negative trial while CPOST was a positive trial? Was it a different patient population enrolled? Was the timing of adjuvant pembrolizumab from completion of radiotherapy significantly different compared to, say, what was used in CPOST? And to remind our audience, in CPOST, patients needed to start cemiplimab within 2 to 6 weeks after completion of radiotherapy. With pembrolizumab, that gap was much longer. It was between 4 to 16 weeks. Did that make a difference in terms of the start of adjuvant therapy? Interestingly, there was also a higher death rate that was observed in the pembrolizumab arm, but it's unclear why that was. And we are yet to see the manuscript from that study. So once we hopefully see the manuscript, we will be able to maybe try to tease out what was truly different between these two trials that led to a positive result on one side and unfortunately a negative result on the other side. So what are the next steps in our field here? Certainly the ongoing NRG study that Dr. Wuthrick's been closely involved with is now trying to answer the question, should we use preoperative neoadjuvant cemiplimab for patients who have stage 3, stage 4 resectable disease and randomize them either to preoperative therapy versus standard of care surgery followed by postoperative radiation? And this is an ongoing cooperative group effort looking at event-free survival as the primary endpoint. We also have an intralesional trial that's a phase 3 study that's currently ongoing. This is specifically for smaller tumors that are located on the head and neck, the hand, the pretibial surface. This excludes patients who are immunosuppressed or have a prior history of transplant, and what they are receiving is low-dose intralesional cemiplimab 5 milligrams once a week for 6 doses versus primary surgery. And the primary endpoint here is, again, event-free survival in this large phase 3 study aiming to recruit 369 patients. So for this section, adjuvant cemiplimab clearly improves disease-free survival in high-risk CSCC after surgery and adjuvant radiotherapy. I think the optimal approach, neoadjuvant versus adjuvant, for this group of patients is yet to be defined. And again, we would ask the question, Sue brought it up in a provocative manner, what is the role of adjuvant radiotherapy in this era where we have effective systemic immunotherapy? And I think one could argue that we need to reevaluate that potentially in a clinical trial. Evan, you have a question?
Yeah, I completely agree with you. The one interesting thing about how we think of the use of adjuvant radiation therapy to the nodal basin in this population too is also in considering what other therapies this patient might be able to get down the line. So our patients that have a kidney transplant or who have a major reason why immunotherapy could cause them some significant problems if they had to have it. Knowing that detail about them does change my perspective on adjuvant radiation therapy. So those that are not good candidates for anti-PD-1 immunotherapy, I'm more likely to express that they benefit from radiation therapy in that setting. You don't want to get to a recurrence in that patient versus those that may have all of those options. Then I think it's a much more of an open question.
So very briefly, we'll revisit options for unresectable disease, starting with a case. You now have a 63-year-old male. You can see on this photograph has a large scalp lesion that's been there for about 4 or 5 months, drainage and clearly complaining of pain. It's a 4.5 centimeter ulcerated mass that is clearly fixed to the scalp vertex on examination, and pathology shows a well-differentiated squamous cell with keratoacanthomas features. He does have comorbidities, congestive heart failure, ejection fraction 25%, has a pacemaker, prior cerebrovascular accident with residual weakness, carotid stenting, and a prior history of pulmonary embolism as well. His PET-CT scan shown at the bottom right showed localized disease, but the mass on the CT portion was abutting and inseparable from the skull. And on multidisciplinary discussion, he was felt to be a poor surgical candidate. So we decided as a multi-D group here to directly move forward with cemiplimab therapy. And certainly one could bring in the discussion of radiation, which I will in a minute. So we started him on cemiplimab. You see the first photograph. He's starting to demonstrate an early response after 4 cycles. He's clearly had a clinical partial response, and now after 8 cycles, a clinical complete response to therapy. Feels great. Pain has gone away, and we see this quite frequently. No significant toxicity from cemiplimab. So real questions, the clinical questions are, is this a patient that either now or maybe even previously at the 4-cycle mark, should we have consolidated with definitive radiotherapy? Or if we continue down this path, how long should we continue treatment? Should we continue for up to 1 year or 2 years, as the original trial did? Dr. Wuthrick's been closely involved with the Rampart study, which identified or which was looking at early versus delayed radiation for these patients in the context of giving them systemic therapy without any surgery at that point in time. And that trial is currently pending assessment and evaluation of final results being led by colleagues at Memorial Sloan Kettering. So the EMPOWER study, just to refresh everyone's memory, was what led to the approval of cemiplimab. There were 3 cohorts, and essentially across cohorts 1 and 3, which was metastatic disease, cohort 2 was locally advanced. You see high response rates of 42 to 50%, and complete response rates as high as 20% in the metastatic cohort, and very impressive median progression-free survival as well as duration of response for these patients, with 88% of patients maintaining their response at 12 months and many of them continuing it at 24 months and beyond. The other drug that we commonly use in this setting that is also approved is pembrolizumab, and this was based on Keynote 629. Similar response rates, about 50% in the locally advanced setting, and a small number of patients, about 9%, discontinued treatment due to toxicity. And based on this study, as well as the CARSKIN trial, pembrolizumab was also approved for the treatment of locally advanced unresectable or metastatic disease. And more recently, cosibelimab joined this group of drugs. Cosibelimab was approved in December 2024. It is a PD-L1 inhibiting immune checkpoint inhibitor that specifically has interaction with PD-1 and B7.1 inhibiting that interaction. But additionally, it has another unique mechanism of action through antibody-dependent cytotoxicity as well as complement-dependent cytotoxicity. And this was long-term results that Dr. Ruiz presented and published recently on 109 patients. Response rates, again, similar to the other 2 drugs, 50 to 55%, with complete response rates now ranging between 13 to 25%, and very impressive durations of response as well. So we now have 3 drugs to choose. What is interesting about this drug was only a 3.6% grade 3 immune-related adverse event in that clinical trial. There were no grade 4 events, and about 6% of patients discontinued therapy secondary to toxicity. So whether this has a more favorable toxicity profile, I think we're going to need more data and more information, and quite frankly, just using it ourselves. It just got available for commercial use in the United States in January 2025. So many places are still looking to put this on formulary. What about beyond anti-PD-1? We have a third of our patients that don't respond or eventually going on to developing acquired resistance. We had looked at anti-EGFR-based therapy with cetuximab in a small cohort of patients here at Moffitt, and we noticed some very impressive results of 64% response rates, and I think that needs to further be evaluated in a prospective manner within all the limitations of a single institution retrospective look. And this was the iTackle study that asked a slightly different question in a prospective manner. These were patients that were treated with pembrolizumab. 44% of them had response rates to upfront pembrolizumab, but when they progressed, 23 of them went on to getting the combination of pembro plus cetuximab and had a response rate of 44% in those 23 patients. So while that's an impressive number, asking the question, does it reverse the resistance to pembrolizumab, I would make the argument we don't know whether we would have achieved the same thing with single-agent cetuximab by itself. And as you can see, the grade 3 and 4 treatment-related adverse event was 35%. Yeah. So summarizing this section of locally advanced disease, it's clear that anti-PD-1 or PD-L1 monotherapy remains the current standard for these patients, but we need to continue ongoing investigations and determine what we need to use if they are refractory either in the primary or in the acquired setting.
So just a couple questions, and then we're going to move on to Evan's presentation. And incidentally, in terms of this issue about whether one PD-1 agent or PD-L1 agent has different autoimmune toxicity, which I don't think we've seen that much of, or much thought about it. But I love the placebo-controlled, there are a couple of placebo-controlled trials of immunotherapy where there was a fair amount of autoimmune toxicity or immune toxicity in the placebo arm, which kind of tells you it's not necessarily that easy to determine autoimmune toxicity. But anyhow, the one thing I did want to get back to, I think is a pretty important point, Nikhil. You say anti-PD-1 monotherapy standard of care for advanced disease. And then, of course, you brought up the issue of adjuvant situation. From your point of view, what would make a patient eligible to receive adjuvant IO, adjuvant cemiplimab? What type of risk situation would justify that?
I'm actually very careful with that, and I would offer it only to those patients that clearly meet the C-post criteria. That is, multiple positive nodes or, a short time to relapse but meets all the rest of the criteria that were highlighted, because those are the ones that I feel may derive benefit. If we simply use the patients who went on to the TROG study, for example, without really defining that high-risk subset, it very well could have been a negative trial. And, at our tumor boards, Evan and myself often will have this discussion is what's the benefit of treating the patient now versus treating the patient maybe potentially later at the time of relapse, particularly because many of these patients, as I showed you in that second case, have excellent outcomes at that time as well. And I think long-term follow-up from CPOS may shed some light on that. The other thing that's important is the patient comorbidity. You have an older, infirm patient, I would be far less enthused about offering them adjuvant therapy, and I would say, let's just observe, as Vishal said, for that case.
So it's pretty common that people start out with the entry criteria for the trial, but also we've seen that as time goes on, people get more comfortable with it. They start rethinking whether or not maybe low-risk patients would be. I see that again when I think about adjuvant CDK inhibitors in breast cancer. We've seen that discussion. Just one other point, and really related to contraindications to IO, Sue. So obviously, I think Evan referred to patients with transplant, particularly heart transplant or liver transplant. IOs have been out there for a while, but prior autoimmune disease obviously is a huge issue. So I'm curious, Sue, both in the adjuvant but also in the metastatic setting, what would you consider an absolute contraindication to IO?
Yeah, there are certain things I consider absolute contraindications. Some autoimmune diseases, particularly ones that are like neurological, or if they had a history of myocarditis that we can't really tease out. Patients that, are liver and heart transplants, ones that we don't have some type of organ replacement for. But I do tend to treat patients with autoimmune disease after having a deep discussion. Even some patients with IBD, there are really good medicines out there now that sometimes you can do both at the same time and really able to balance the toxicity with efficacy. But I think this is more nuanced, and I'm more inclined to offer it for a metastatic patient than an adjuvant patient.
Yeah, and this discussion goes on all the time in oncology. Evan, we wanted you to cover the issue of radiation therapy in the management of squamous cell and basal cell.
Absolutely. Thanks very much, Neil, for the opportunity. Let's talk about the incorporation of radiation therapy into the multidisciplinary management, sort of emphasizing that the best plan for these is multidisciplinary management, because there is such a crosstalk between dermatologists and plastic surgeons in the management of these patients. So I wanted to just briefly break it down into three different bins. Adjuvant radiation therapy, meaning the treatment of patients with radiation therapy after their definitive intent surgery. Definitive radiation therapy, meaning there is no plan for a definitive surgery, so that the radiation therapy itself is the main management of the local disease. And this could occur with or without radiosensitizing therapy like platinum chemotherapy or cetuximab, or could occur with immunotherapy. And as you'll see here in a minute, we really don't know which of these combinations really is optimal. And then a third sort of concept is maybe one that I'm introducing, but consolidative radiation therapy. Obviously, for this audience, we're pretty comfortable with the idea of what consolidative therapy means. But what I mean by this is that the patient has had a good response to an upfront systemic therapy. And the question is whether that should be consolidated with additional local therapy, whether that was surgery or, in this case, radiation therapy. So those would be the three main topics. So I wanted to just give an overview, typical adjuvant radiation therapy indications. Now, this has a lot to do with what we had previously discussed with nomograms, et cetera. But almost an uncontroversial indication for adjuvant radiation therapy is a positive margin excision without a plan to take more tissue. So a positive margin, if you follow those patients out long enough, we did a look at this at Moffitt in the past. If you follow out 2 or 3 years, about 85 to 90% of those patients will have a local recurrence. Patients with extensive perineural invasion. So I said extensive because sometimes you'll get a pathology report back that just says perineural invasion, and it's worth asking the pathologist to clarify. So a very small caliber nerve, one instance of a very small caliber nerve involvement of perineural invasion has not been closely associated with risk for local recurrence. However, if there's extensive perineural invasion, then that has been, as has involvement of nerves once they get down deeper into the tissue and are of higher caliber. So the cut point has usually been 0.1 millimeters. So if the nerve has a diameter of greater than that, then it's a larger, a more medium-sized nerve, and that has been much more closely associated with risk of local recurrence. And we think that's because as tumor runs along the nerve, it can give you sort of a false negative margin, because you may see an area where the nerve is involved and then the nerve may look normal, and then it gives you this sort of false sense that there's a negative margin when really there's tumor further on down the nerve. T4, invasion of bone, cartilage, skeletal muscle. Those that have already locally recurred, I think this is an important one. If you did a surgery by a good surgeon, done in a good, with a good technique, and 6 months later they had a local recurrence, and then they have another surgery with a good surgeon and a good technique, seems hard to imagine that they're not at a high risk of local recurrence, and that's been borne out in the data. And then sort of this sort of multifocality, whether it's the rare squamous cell carcinoma that has satellitosis, or just this large sort of field cancerization effect on someone's scalp, for example. And so, like we have sort of talked about recently, just now, I at least heavily use nomograms to help give some number to the likelihood of local recurrence, and use those for our discussions about adjuvant radiation therapy. Typical indications for adjuvant radiation therapy, nodal basal, we talked about this a little bit already. So multiple nodes, lymph node greater than 3 centimeters, extracapsular extension. The most important one of these is probably extracapsular extension. It's the thing that bears out the most correlated with regional recurrence. And we talked about how I also cache this in a pro-con risk-benefit relationship with the risk of lymphedema. So much more likely to offer adjuvant nodal basal radiation therapy to the neck, where there isn't a long-term risk of lymphedema really, versus a little more cautious in the groin. I think that this paper is pretty important, and I try to include it a lot because it is one of the better looks at the benefit of surgery followed by adjuvant radiation therapy versus surgery alone. And when you see this is a retrospective paper, but it does show the potential benefit in even things like overall survival and progression-free survival of adding adjuvant radiation therapy. So I think unless there's really a good reason not to, for patients with multiple nodes or extracapsular extension or a large lymph node, I think even with the availability of anti-PD-1 agents in the adjuvant setting, I still think that probably the baseline algorithm should be to treat these patients with radiation therapy. So what do we do about the situations that Nikhil was talking about before, where we're treating an increasing number of these patients with upfront immunotherapy? So a fair percentage of them are going to have a response to that immunotherapy. So then we're going to go on to surgery. And then should we be always treating those patients because they were locally advanced at the beginning, like they had, cartilage invasion or had a large size or were poorly differentiated in the beginning? Should we treat all of those patients after surgery with radiation therapy because they were locally advanced in the beginning? Should there be some sort of selection based on the response to immunotherapy? I don't think we know the actual answer to this question, but what we can tell a little bit from the Neil Gross data that was importantly published in the New England Journal of Medicine after 4 cycles of cemiplimab and curative intent surgery, they have been following these patients, and about a third of them, so about 36% of them, did not have a pathologic complete response or a pathologic major response. And so probably for that group of patients, they have a pretty high risk of local recurrence. And so I would sort of advocate that until we know a little bit more, those that don't have a great response should probably go on to postoperative radiation therapy. And basically in our own tumor board, we're using the patient's YP status. So they're after neoadjuvant therapy pathologic T and N stage as what we're using to evaluate their candidacy for adjuvant radiation therapy, if that makes sense. So I'm not using what they were prior to neoadjuvant immunotherapy. I'm using after their neoadjuvant immunotherapy. What is their stage after that? What are their risk factors after that to assess for adjuvant radiation therapy? So a patient who's had a great response, a major pathologic response, whose tumor goes from T3 to T1, those patients probably can safely avoid additional local therapy after surgery. So yeah, this is basically saying that again, although we're really looking forward to seeing some additional data. So that Gross publication from MD Anderson, they have a second part that's looking at what happened to patients after their adjuvant cemiplimab. Did they get adjuvant radiation? Did they get observation, and how those patients do more long-term? And so we're very interested in seeing how those pan out before we are really going to have data to guide this situation. One of the great things about neoadjuvant immunotherapy is that it works a lot of the time. One of the problems with neoadjuvant immunotherapy is that it works a lot of the time, and then you're trying to figure out what you're going to do next because there isn't an obvious playbook that has been developed that's evidence-based at this point. Okay, let's shift gears a little bit and now talk about definitive radiation therapy. And now I wanted to talk about sort of early stage disease and kind of compare and contrast the pros and cons of radiation versus surgery. And obviously in surgery, we're talking, depending on the location of the malignancy and who's providing the care, either a micrographic surgery or a local excision technique. Those are obviously different, but for the patient, the risks of surgery kind of are similar in that it's the sort of pros and cons in that it's a one-day event generally. The surgeon is making an incision. The surgeon is either using a skin graft or a reconstructive technique to close, and they have to heal that wound. The radiation therapy part of this can be done in a number of different ways. And just since this is a non-radiation oncologist audience, if you'll indulge me for a second, the whole strategy of radiation therapy is to use some kind of energy to create DNA damage events in the tissue. Those DNA damage events are well repaired by your normal healthy cells. You have a lot of DNA repair proteins in most of your tissues. So the average muscle, bone, ligaments, connective tissue cell has lots of repair and maintenance machinery. One of the things that happens when squamous and basal cells go rogue and start to become a carcinoma and start to divide out of control is those cells start to make many more proteins that have to do with cell division and invasion and all the hallmarks of cancer, and therefore make fewer of the repair and maintenance proteins. And so that is the difference that radiation therapy basically exploits. And it delivers this DNA damage. That DNA damage is repaired by and large by the normal healthy cells and not very well repaired by the tumor tissue. And then you hit it again. And there's a lot of repair by the normal healthy cells and not much by the tumor tissue. And you continue to do this until it becomes a cumulative effect on those tumor cells versus a far less than cumulative effect on the normal tissues that were repairing themselves along the way. And so that's the whole strategy. How you create that DNA damage is the purview basically of the radiation oncologist, but it could be high energy X-ray based. It could be intermediate X-ray based. You have seen the proliferation of some of the superficial orthovoltage based X-ray technologies in some dermatology practices. It could be with a particle, such as electron therapy, not for skin cancers, but there's also proton therapy units that are proliferating among the academic centers in the world. And then I talked a little bit earlier about brachytherapy. Brachy is the prefix that means close or near. And it's the idea of bringing a radioactive source right near the tumor and having, as it decays, it is shooting off gamma rays, and those gamma rays create those same DNA damage events as the electron therapy or as those X-rays are. And so that's the strategy. And then the determination between surgery and radiation therapy is a game of would you rather. Would you rather have an incision in the area where the tumor is and a one-day event and heal? Or would you rather come to the radiation center, many times for about a 15-minute treatment, which will create a sunburn-like skin reaction on the target tissue, and obviously is less convenient but does avoid incisions. Other things to consider is that radiation therapy often causes hair loss in the area that we're treating. So whether that's facial hair, head hair, leg hair, all of that, the patient will have permanent epilation of that area. And generally, with the current regimens that are used in radiation oncology, the cosmetic outcome is actually pretty good. You don't see, generally scarring or a lot of telangiectasias in the area. We do obviously consent patients for that, but the overall cosmetic outcome is often quite good with the current techniques. So I think that cosmesis and convenience are the primary considerations because these are early stage squamous and basal cell carcinomas, so people generally aren't dying from them. That's more about the convenience and the overall cosmetic outcome. I think that sites well suited for radiation therapy, particularly, are around the areas that are the most difficult to reconstruct. So contours of noses are difficult to reconstruct. The oral commissures are difficult to reconstruct. The border between the vermilion part of the lip and the cutaneous part of the lip are difficult to reconstruct well. The ears or eyelids may be difficult to reconstruct well. Also, sometimes overlying a joint. If the malignancy is going to be large enough that it's going to require a skin graft or some kind of complex reconstruction, sometimes overlying a joint that's very difficult to heal well, and radiation therapy may be a better choice. Sites well suited to surgery is really many of the other ones because surgery is obviously the mainstay here and quite convenient for patients. And they have the benefit of, at the end of the day, the tissue is turned into a pathologist generally, and the pathologist declares that this, there's negative margins and the problem has been generally solved. And that's nice, where you don't really get that from radiation therapy. We don't do confirmatory biopsies generally. We don't do, additional therapy beyond the radiation. It's just basically observing that area of the skin going forward as the main way of sort of like showing that, time test that it's gone. Both surgical options and radiation therapy options have a greater than 95% rate of long-term local control of these early-stage squamous and basal cell carcinomas. Now, whether that number is 95 or 98 or 99 kind of depends on which of the studies you're looking at and how large a tumor they included and a bunch of other details. But there has never been a head-to-head randomized trial between surgery and radiation therapy, probably never will be because they're such different treatments. But I think what you can do is you can look back at very, very large series of thousands of patients and conclude that both of them at least have about a 95% or greater long-term local control when treating early-stage cancer. Bad places for radiation therapy generally are areas that are poorly vascularized. So I'm talking about the legs and feet mostly. So if the patient has some elements of peripheral vascular disease and has, poor pulses or other, obvious stigmata of peripheral vascular disease, this is not a great candidate for radiation therapy to the lower extremities. You can create a chronic ulcer that never heals. These, unfortunately, though, are not great candidates sometimes for surgery either, for the exact same problems, is that, skin grafts have a hard time in these areas, and the surgical wound may not heal. Radiation therapy is also used for definitive management of local and regionally advanced disease, either as a standalone or with concurrent cisplatin, concurrent carboplatin, concurrent cetuximab as radiosensitizers, or as part of a strategy with anti-PD-1 immunotherapy. As I mentioned before, we do not have any real randomized head-to-head studies in cutaneous squamous cell carcinomas that look at platinum chemotherapy versus cetuximab, or one of the classic radiosensitizers like cisplatin cetuximab versus immunotherapy. So we really don't know which of these agents is the best. So it's a co-decision between the radiation and medical oncologist about what the patient can tolerate. The argument for cisplatin would be something like we use platinum-based chemotherapy with radiation therapy in locally advanced squamous cell carcinomas of many other types: lung cancer, cervix cancer, anal cancer. Go down the list of squamous cell carcinomas in the body, and we've basically proven in other settings that the addition of cisplatin improves response. But we don't have that direct proof in cutaneous squamous cell carcinoma. One interesting study that Dr. Khushalani recently just referenced was this Rampart study, which is recently completed and is now undergoing data analysis. And this was an effort to look at the use of immunotherapy in conjunction with definitive radiation therapy, in which patients got 2 infusions of cemiplimab, a reevaluation for their response. As long as they didn't have progression of disease, they got 2 more infusions of cemiplimab and then underwent definitive radiation therapy. And so we are likely to get to give those results for ASCO this year. Okay, let's switch gears a little bit and talk about consolidated radiation therapy. I think this is interesting because it's only because of, like I was saying, the great results from neoadjuvant immunotherapy that we're even thinking about this. But I find this paper to be very interesting. It looks at whether we need to do anything for patients who've had a great response to immunotherapy up front. And so this study was called the Descomate study. It was a relatively small study, but it divided patients after 4 cycles of immunotherapy into those that had a complete clinical response and those that did not, and then sent them down different treatment algorithms. So they called the complete clinical response if all of the visible tumor went away, and then they called them a complete surgical response if they went and did some random scouting biopsies of the area, and then they might declare them a complete surgical response. So in this situation, they followed these patients out over time and have some sort of interesting data. So basically, 63% of the patients on this study had a complete response. 48% of them had a complete clinical response. 15% of them had a complete pathologic response. And you can sort of see these Kaplan-Meier curves that those who had both a complete pathologic and complete clinical response, that red curve there, they only had 1 event out of those 17 patients going forward. So another way to say that is 16 out of the 17 people who had a complete clinical and pathologic, by pathologic we mean scouting biopsy response, did not need any other further therapy, and they could completely de-escalate their therapy to not have surgery and not have radiation therapy. So this is only at 12 months, so we don't really know if this is durable or not, and their immunotherapy is ending at this point. So whether what's going to be really interesting is what happens between months 12 and 48 on this study, and that's, I hope, going to let us know whether we need to do consolidative radiation therapy for patients, or whether it's surgery or some consolidative local therapy. That could be surgery or radiation therapy for these patients. And at the moment, because we don't really know, I think we're taking this on a case-by-case basis. So if the consolidative radiation therapy still would be an area that's very difficult from a toxicity profile, like we had a patient recently with a squamous cell carcinoma that was on the temple, on the scalp, on the eyelid. They had a great response to immunotherapy, and we chose not to do consolidated radiation therapy for that patient because of the perceived toxicity of the radiation therapy. So if the patient has an area, though, in the body that the consolidative radiation therapy would be quite a bit less toxic, then we are considering patients for that. So with that, let's go into just a couple of quick cases. This was a 72-year-old man with a 5-month history of an enlarging left temple skin lesion. The surgeon who saw this patient was concerned about the location of the tumor and the potential damage to the temporal branch of the facial nerve, resulting in paralysis of his temporal area with resection, referred him to radiation oncology. This patient had 66 gray and 2.2 gray fractions without any radiosensitizing therapy for his T2N0 cutaneous squamous cell carcinoma. And here are some 6-month after photographs of him. It's kind of illustrating that I wanted to illustrate the typical look of the malignancy after a course of radiation therapy. You can see that there is still a divot there. There is still some residual erythema at 6 months. And you can see some hair loss that he has from the radiation therapy. He was treated with an IMRT plan to keep dose off of his eye. And this is basically the typical cosmetic outcome. Have any questions about this case?
When you counsel these patients, what do you tell them is the likelihood of complete response? And what does that response depend on from a radiation perspective?
So T1 malignancies have 95+% clinical response. They almost all go away, at least initially. Those 5% or so that are going to recur will often recur much later, so many months later. As the tumor gets larger, that number goes down, but still for T2 cancers, the counsel is 80% long-term local control. And for T3 and above cancers, that number goes down to about 60 to 65%. Those that involve lymph nodes or are locally advanced, in that there's a large primary and large lymph node, that number probably goes down now to about 45 to 50% long-term local regional control. with radiation therapy alone.
Let's hear about your 88-year-old man.
Yeah, this one is not a surgical This is an 88-year-old guy with a erosive squamous cell carcinoma of the lateral cheek onto the ear. And you can see the sort of positive nasal cannula sign there that tells you that this patient may not be the greatest candidate for a surgery. This would probably have required a skin graft, a partial auriculectomy. And so this patient was treated with definitive radiation therapy as well. He was treated with a more hypofractionated course, 55 gray and 2.5 gray fractions. And here are his 6-month pictures where he's had nice resolution of the malignancy. He still has a little bit of telangiectasias and erythema in the area, but overall looks pretty good.
Any questions about this case? Any comments?
The key issue becomes is when do we add systemic immunotherapy to this? Or do we defer and say, let's just definitive radiotherapy and leave immunotherapy out of it? Or will immunotherapy actually add to the benefit that you're already showing us, through 2 remarkable cases and responses? Yeah,
that is an individual case-by-case discussion for sure. I think particularly for the elderly patient here with a lot of comorbid medical conditions, including some major respiratory problems, that one was a little easier because the last thing this patient needs is any kind of systemic toxicity. I remember this patient quite well, and he was not a candidate for, even a biopsy was making everyone nervous. So that one was pretty easy. The patient beforehand very well could have been treated with upfront immunotherapy. But it's a big question because you are opening them up to potential long-term toxicities with thyroid hormonal problems. And when patients have a pretty good likelihood of being cured by a local therapy that avoids all of those, I think each patient deserves a multidisciplinary discussion about the pros and cons of immunotherapy. And a lot of times our patients will guide us with their preferences.
Sue, we're going to talk now about basal cell. We've talked a lot about squamous cell. Now we're going to talk about particularly systemic therapy considerations with basal cell.
Yeah, thanks so much. So I'm actually going to talk about basal cell, which is actually the most common form of skin cancer, but we're going to take a page from the Cutaneo's playbook and also talk about some new strategies. So this is what I'm going to be talking about. So I want to start with early phase clinical research in non-metastatic basal cell because metastatic basal cell is not very common. I think the general oncology community knows that, what we treat metastatic basal cell or locally advanced basal cell with is hedgehog inhibitors. I often tell my fellows how to remember this is, hedgehogs like to eat basil leaves. I don't know if that's true, but that's a good way to remember it. So this is a trial that was done in 2014. It was a French trial, phase 2, 55 patients with locally advanced basal cell. This was looking at the use of a hedgehog inhibitor, vismodegib, in patients with basal cell carcinoma. Their primary endpoint was a percentage of surgical downstaging. And you can see most of these patients got 4 to 10 months of treatment before surgery. The median was about 6 months. 80% of them had surgical downstaging, and about half of them actually had a clinical CR that was confirmed by biopsy. But what you notice here is that the 3-year recurrence, it was 36%. So that's pretty high. And this is also listed in the NCCN guidelines. While you could consider this as a neoadjuvant strategy, particularly for patients that have, a basal cell that is in a precarious location, a lot of these occur on the head and neck. We always have to remember that the recurrence rate is not low. And so the key learning point here is it can reduce surgical complexity, but you may need to follow it up with something after, because the recurrence rate does seem to be high. We do know that patients with basal cell often have finger-like projections that grow, and that may contribute to reduced tumor clearance. There's another study I want to highlight. People are like, okay, if we can use hedgehog inhibitors and, immune therapy has done so well for cutaneous squamous cell, for basal cell, can we combine them? And this was a study done by the dermatology group at Stanford that was done in 2017. And this was a phase 1B proof of concept trial. Just had 16 evaluable patients split into 2 arms, pembro monotherapy or combining pembro with vismodegib, a hedgehog inhibitor. And you can see the primary endpoint here was the overall response rate. It is higher in the pembro monotherapy. And in this group, these were patients that had progressed on a hedgehog inhibitor. For the arm 2, where you had the combination of pembro and vismodegib, again, numbers are small. They did not have a progression on a hedgehog inhibitor, but it doesn't seem like the combination really does that much, and it does not seem to be better than monotherapy. But this gave us some information back in 2017. This was published in 2019, that perhaps immune therapy has some activity in basal cell. So then this was a neoadjuvant adjuvant, so a perioperative pembrolizumab study in basal cell carcinoma of the head and neck. So this was for resectable basal cell carcinoma that was deemed to be high risk. This was also a small study, more of a proof of concept, but these patients, like the patients in the cutaneous trials, got 4 cycles of neoadjuvant cemiplimab. Then they got a standard of care surgical resection, and they also got adjuvant pembrolizumab after. And they had 13 patients, 11 of which went to surgery. Here, the pathologic complete response rate is much lower than what we typically see in squamous cell, which is 23% here. And I think from the Neil Gross trial, we know that this number is about 51% in cutaneous squamous cell carcinoma. So this was just the first trial that we have looking at perioperative PD-1 and resectable basal. So we can see some early signals, but this is a completely different disease than squamous cell, even though both are derived from keratinocytes. So I think we have a lot to still learn. This is another study that builds upon, if we see activity with immune therapy with PD-1 agents, can we expand that to other immune therapy agents? And this was a poster that was presented at ESMO this past year, where instead they looked at immune therapy first. So typically we often give hedgehog inhibitor first, but this was looking at patients that got immune therapy first before they ever got a hedgehog inhibitor. And you can actually see that getting first-line Nivo alone for locally advanced basal cell carcinoma, they had an overall response rate of 52%. And so that's pretty good compared to if you were doing this in the second-line setting, and as I'll show in a couple slides later. For patients that ended up progressing on first-line nivolumab, this study showed that they could salvage 31% of those patients with another drug, nivolumab plus relatlimab, which is a LAG-3 inhibitor. And then the numbers are again small, but of the patients that progressed on the nivolumab and relatlimab, which there was only 2, they salvaged 1 patient with nivolumab and ipilimumab, which is more along the lines of a melanoma regimen. So just highlighting that, immune therapy seems to have activity, probably better in the first line setting if you have not received a hedgehog inhibitor. So where can we take this? This is another study that was recently published last year where this is looking specifically for patients with locally advanced disease that is considered unresectable. And I think for these patients, you always wonder the definition of resectability. Some surgeons, I've heard use the term aspirationally resectable. So this looked at actually using induction with vismodegib, which is a hedgehog inhibitor, which works quite well, but we're limited by toxicity, and then actually getting vismodegib with radiation together and then stopping treatment after that. So you're not on systemic therapy for a long time. And the primary endpoint here was 1-year local regional control. It was pretty high, 91%. And the 5-year PFS was 78%. So this is another option that can be considered for patients with, locally advanced but disease, not metastatic, unresectable, where you may not want to, keep them on therapy for long. It's a more of a definitive strategy. So for, where did we get the data for our hedgehog inhibitors? So vismodegib, this comes from the AirAdvance study. This is the pivotal trial that led to the FDA approval back in 2012. The take-home message here is that for both locally advanced basal and metastatic, these drugs do work well. The overall response rate was 60% in the locally advanced setting, almost 50% in the metastatic. The duration of response is over 2 years in the locally advanced setting, over a year in the metastatic setting. So these drugs do work. They are durable when you are on the drug, but the problem is that these drugs have considerable toxicity that I'll allude to in the next couple of slides. The other hedgehog inhibitor is sinidegib. This is the BOLT study. This is the study that has the longest hedgehog inhibitor follow-up available. This was also the study that led to FDA approval for this medication. Very similar numbers. As you can see, the overall response rate is 56, and they studied 2 doses of this, but the 200 milligram dose had a more favorable adverse event profile. But interestingly, this hedgehog inhibitor compared to vismodegib has about a 10% lower incidence of adverse events. And I think that's what a lot of us see when we prescribe this drug. And I think it's related to the different pharmacokinetics of the agent. So what are we concerned about if these drugs work really well and the duration is pretty good? Well, most patients actually have to discontinue these drugs 6 to 12 months in, sometimes even earlier, because they experience a lot of low-grade adverse events that affect their quality of life. Most commonly, dysgeusia, hair loss, muscle cramps, fatigue. People have looked at different ways to dose these, maybe 3 months on, 2 months off, or 6 months on, 2 months off. And we haven't really found, a great strategy. And the other problem is, we can encounter resistance. These drugs work by targeting the hedgehog inhibitor pathway. With smoothen is one of the genes that's mutated often. And so you can often have mutations in the smoothen gene to cause secondary resistance, among other things. So based on this, we know that we need better drugs out there. And that's where the study 1620 comes through. So doesn't have a fancy name, but this was a study that led to the approval of the first immune therapy, cemiplimab, for basal cell carcinoma. This is a phase 2 open label study looking at both the locally advanced and the metastatic population. And to get on this study, you had to have either progressed on, be intolerant of, or have no response to a hedgehog inhibitor after being on the drug for 9 months. And most of these patients were older. They got almost 2 years of cemiplimab. The primary endpoint was the overall response rate. So this was the first systemic therapy that was evaluated after looking at failure from a hedgehog inhibitor. And you can see the overall response rate is 31%. Pretty good, but not as good as squamous cell. The median duration of response has not been reached. About 6% of the patients had a complete response. And so this led to the FDA approval in 2021. And then for the metastatic cohort, they had 22% of patients respond, and the median time to response was 3 months. The median duration of response also has not been reached. So based on this, cemiplimab got accelerated approval in 2021, but the FDA actually granted it full approval for metastatic disease in 2023. The cemiplimab safety profile in this disease is similar to what we have experienced with cutaneous squamous cell. I think most of the oncology community is pretty familiar with the adverse event profiles of PD-1 agents. Promising agents under investigation. So we always need better drugs, things that we're looking at right now. So I mentioned nivolumab and relatlimab could salvage some patients that don't respond to PD-1. And there's a study that I'm actually part of that is looking at this in the neoadjuvant setting. We're also looking at novel hedgehog inhibitors like taladijib, which may overcome some resistance mutations. And then we're also looking at downstream ways to target this pathway using Gli inhibitors to bypass the smoothened resistance that we can sometimes see. So just key takeaways, first-line immune therapy shows promise in non-metastatic BCC. Induction with hedgehog inhibitors with radiation can offer a definitive and durable treatment for unresectable disease. The 2 long-term studies from Aravance and Bolt confirm that hedgehog inhibitors do work, but we have problems with tolerability and resistance. Cemiplimab, based on study 1620, is the first and only FDA-approved immune checkpoint inhibitor for advanced basal cell after failure from a hedgehog inhibitor. The responses are durable, and now we have some new drugs that we're looking at for future treatment of basal cell carcinoma. So I'm going to go through 2 quick cases. So this is a 66-year-old male with a neglected basal cell carcinoma of the face, and I feel like, this is not an uncommon scenario where we see neglected disease. As you can see, he has severe soft tissue destruction of the left and central face. He had not seen a doctor in 40 years and had no prior treatment. And so how do we treat this patient? So I treated him with sunitinib for 5 months, and as you can see, he had an excellent response. But the problem is no clearly defined margins for surgery, and I feel like these patients often need some other type of local control after induction with a hedgehog. And so I did treat him with radiation for local control. And this patient, due to concerns about tolerability, instead of doing a concurrent like the study that I mentioned earlier, I just gave radiation alone. And he is now doing well, and it's been 3 years out.
I just want to say it's a really impressive result, and I wanted to echo, I think the Chris Barker study that you mentioned for our listeners has really revolutionized how I look at advanced basal cell, as well as you've so nicely pointed out. And despite that study, I've also taken the approach of treating first up to this kind of response or till tolerability, and then shifting to radiation. And I think it's underappreciated in our medical oncologist community. Really, it was a small study, may have been glossed over, but can really, the results have been remarkable in the handful of patients we followed that protocol with. So I just wanted to add that.
Yeah, no, I've used it a lot even before the publication came out. And I've actually used sunitinib because I find it more tolerable, but the concept is the same and the results are really great. So going back to my second case, so locally advanced basal cell, right orbit. So he was treated with neoadjuvant vismodegib for 4 months, and then this is the outcome of his Mohs surgery. So he got Mohs surgery, wasn't able to clear, then saw a head and neck surgeon or an oculoplastic surgeon for a wide local excision. But he still had multiple areas of a positive deep margin, including the periosteum, multiple areas of the upper and lower eyelid. And this just highlights that even though he got neoadjuvant vismodegib, like mentioned in the Vismoneo trial, he was not able to clear his disease. So I think a mapping biopsy for patients like in basal cell have a very different implication than what we see in squamous cell carcinoma, where it can often be a surrogate marker of pathologic response. So what do we do for this patient? So I tried to retreat him with sunitinib for 3 months because he wanted to try the other one. He was having more pain, but a stable disease on imaging, as you can see here. But he was also having grade 2 dysgeusia, and it was really affecting his quality of life. So because of intolerance to a hedgehog inhibitor, I did switch him to cemiplimab. And you can see here that, this drug, it takes longer to work in basal cell as opposed to squamous cell. But he had a radiographic response after 8 cycles, no clinical progression at all during this time. And even though the study 1620 treated patients for up to 2 years, his good eye is affected. The unaffected eye, he's blind in. And so it was really shared decision-making to really try to get him off of this therapy when he had been doing so well and imaging has been stable. But I was finally able to get him off after 3 years, and he's been off treatment for a year and still doing well.
Those are both incredible cases. I want to move on in a second and let Vishal comment, but just any thoughts starting with you, Vishal, in terms of what we know in terms of these people who have neglected disease. We see this all across oncology, but it's so much more visible with skin cancers. Any comments on working with these patients, how they adhere to therapy, the social situations that you encounter?
Yeah, it's a practical issue, especially for the basal cell patients, because oftentimes there is some other extenuating circumstance that leads them to get to this point, whether that's psychosocial, socioeconomic, or something else. And so that's why I said the team is not only the multidisciplinary team, also can involve social workers and the extended family. That's key. To Soo's point, my preferred hedgehog inhibitor also is sunitinib, because sometimes you need to limit as many barriers as possible to get effective therapy, and the tolerability of sunitinib is significantly higher. So reaching for that and using alternate dosing can help. But I say the basal cell, the disease control is the goal, not necessarily cure, because they've sometimes lived with this for 10 or 20 years, getting comfort, bleeding under control, lack of pain, and just control. And so understanding what's going to be your biggest barrier, the trust and other issues may be your biggest challenge rather than the therapy and the response.
Nikhil, any thoughts about where we're heading with basal cell in the future? What new agents are you excited about? Do you see checkpoint inhibitors moving up more and becoming more involved? Any thoughts about where we're heading?
Well, I think certainly more availability of these drugs, as Soo already mentioned, the taladegib as well as the GLI inhibitors. I think I've been impressed by the Nivorella data that the folks at Johns Hopkins have been pursuing and trying to see whether or not that can actually come towards the frontline setting. Certainly that would be worthwhile if it actually meets endpoints in terms of efficacy. Of course, we have to think about toxicity, because nivolumab plus relatlimab clearly has higher, longer-term, and more chronic toxicity than, say, monotherapy with anti-PD-1. So we have to balance that toxicity, particularly in this group of patients where their emotional psyche is quite delicate. And so you literally have to handhold many of these patients, tell them we are being very cautiously optimistic, and make shared decisions with them to help them get to that finish line. Once they see that these drugs work, whether it's the hedgehog inhibitors or the anti-PD-1 inhibitors, I recognize then they look at you with a renewed sense of trust and sort of start trusting the medical system again. And then potentially in some of those who it may not have worked in the first line, or at least developed acquired resistance, they may be more open to considering clinical trial therapy as well. We've also, done a novel approach here at Moffitt. We have an ongoing trial of almost adaptive dosing of the hedgehog inhibitor as opposed to daily dosing, adapting it to their size and the kinetics of response. And we work with our mathematical oncology colleagues here, who then tell us whether to stop the drug for a period of time and then keep measuring growth or continue the drug. and hopefully we'll see some results from that trial in short order.
Evan, any comments you have either about kind of the art of oncology in these patients, but also some of these new strategies, these adaptive strategies that Nikhil just commented on?
Yeah, from my perspective, one of the key questions we ask each other a lot is, should I use hedgehog inhibitor therapy up front for a certain amount of time, try to get whatever response I can before toxicities mount up so much that the patient wants to discontinue, and then go on to the local therapy? And my answer to that question often depends on where anatomically the tumor is. So I think the optimal use of upfront hedgehog inhibitor therapy is in for example, a malignancy that is on the cheek, very near to the eyelid, such that whatever surgical or radiation therapy needs to occur is going to jeopardize that eyelid, be a difficult reconstruction, be a difficult cosmetically. In that case, then let's use hedgehog inhibitor therapy to try to get that tumor as small as it can be prior to the surgery or definitive radiation therapy. If the basal cell carcinoma is in whatever the opposite of that is, in the middle of the back or something like that, then I'm not sure exactly what you gain, because you're really not changing the operation that they're going to need that much if the plan is still to have the definitive local therapy. So I think that those are the kind of things that I consider when we talk about should we start with hedgehog inhibitor therapy in that locally advanced patient.
So, Vishal, I've really been looking forward to this presentation. When I first saw your slides, I'm like, oncologists are going to love this because they never hear about it. So I'm really curious about your comments.
Well, thank you, Neil, and thank you again for including me. I was just also thinking to myself, we've discussed so much great stuff here today, and I want to try to make this relevant to the oncologists and from the standpoint of the dermatologist. Some of my slides here have been covered by my esteemed friends and colleagues, so they stole the mic from underneath me. So I'm going to pivot in real time and try to think about what we have left off. But before we start, I want to maybe run this like a tumor board. I know that was the intent, and present a case here of this is a migrant farm worker who has some issues with care and socioeconomically. He has had no health care, and he's longstanding left lower eyelid lesions progressing slowly over 5 years. It just wasn't bothering him up until this point. And this is not uncommon as a dermatologist. We get lesions around the eye that are fairly localized. This is under 2 centimeters in the widest diameter. And it's in the infraorbital cheek to eyelid area that's beginning to maybe cause an ectropion. There's some inflammation and swelling. But other than that, it's fairly localized. So open it up to our group here. I know we don't have a surgeon in mind, and then from a surgical standpoint, this was brought to me as, is this surgically resectable? And I would say, absolutely. As Sue says, I 100% have the aspiration that I can surgically resect this. And for those who may be oculoplastics or Mohs surgeons, what we've described here would probably require a huge flap, because 50 to 60% of the lower eyelid would be lost. It'd be hard to retain the lower eyelid, even though the lesion is on the infraorbital aspect of the cheek. So, Evan, if surgery was not going to be discussed, how do we feel about radiating this right near the eye and that cataract risk?
Yeah, so the technique for radiation therapy in these patients is to use electron therapy, which penetrates relatively superficially, and then put a high Z material shield between the patient's sclera and their inner lid. So in the space that a contact lens goes, we would place a shield there. And so that isolates just the eyelid for treatment. And the shield blocks a extremely high portion of the dose. So the dose in those cases to the lens is under the dose that generally you would get a cataract from. There is some potential infection risk with putting a shield in and out of the eye all the time, each day for treatment, because we would use a long, a 6-week regimen for something like this and go slow near the eye. The other problem is that it does not shield the small lubricating glands of the eye on the inner side of the eyelid. And so some patients will have long-term drier eye, not usually awful xerophthalmia, but drier eye after radiation therapy in this location.
Yeah, and we discussed some of those risks with them if we did surgery and we needed to add radiation. Sue, if something like this presented to you, you're not a surgeon, you don't have to say surgery or not, but just at your group, are you thinking surgery here still or systemic therapy?
No, I would probably treat this patient with hedgehog.
Right. And Nikhil, to you, same question.
To me, this is a multi-D discussion, and if our surgeon says, yes, we can operate with the limitations that you highlighted, I would still pursue surgery first or definitive radiation. Evan has treated many patients like this with excellent cosmetic results.
So we did deem this to be resectable, and this is not uncommon with dermatologists see. And sometimes I think it highlights the point, going at this alone without having that discussion can be challenging, can be tricky, but certainly can be attainable. And we had planned to do surgery, but recognize we may need radiation oncology for positive margins, certainly with oculoplastic surgery. And that was what he was teed up to do. But not surprising, with issues like this for delayed care, there was a missed pre-op appointment. He could not be confirmed for surgery. In about 6 months, was lost to follow-up and then came back. Now with the lesion having progressed to about 3 centimeters. And now the lesion has involved all of the lower eyelid. And it certainly is much more indurated. I think the same issues remain. And in the sake of time here, no, we've progressed. We would call this locally advanced. And as a dermatologist, we begin to say, okay, I'm sending this off. But the question comes up to who? Does this go? Are you reaching for your medical oncologist, your radiation oncologist, or surgical oncologist? Nikhil?
Based on what you're showing me here, this is somebody now that I would consider systemic therapy. Yeah. But I think this patient should also get an MRI or a CT of the orbits to assess what the depth of this tumor is. As you know, many of these basal cells, classic description of rodent ulcer, can burrow much deeper than what we can actually see on the surface.
And that's exactly the discussion we had, both at the first case and what I explained to them. I've taken enough of these out, and with micrographic surgery, you see these roots, these cords going down. And when I was younger, I was eager to cut them out, and now I see them and I am not eager to cut them out, thinking about all the tragedies that have occurred by biting off more than we can chew. And so that's exactly what we did. We had an MRI. It was localized. It began to involve or go up to the muscles just above the septum and the lower eyelid. And so we decided to start a smoothing inhibitor. As I noted, sunitinib is my preferred smoothing inhibitor. And he had reported to have shrinking of the lesion because he missed his follow-up appointment. But we reached out to him through a translator, he said he was having no side effects and he thought the medication was working well, which is what we would expect, and felt comfortable that he could come back in the next month or two. And most of these patients, I usually don't bring back for at least 2 months because the anticipated result and the tolerability is pretty high, and confidence that they can go that long. I see Sue shaking her head as well. Is that the time period that usually when you start people on therapy, 2 or 3 months, Nikhil and Sue?
I agree with you.
Yeah, I mean, that's typically these tumors grow slowly, they respond slowly, very, very similar to their growth kinetics. I tend to be maybe a little bit more OCD in terms of their follow-up, and I will see them, pretty much we will see them on a monthly basis, particularly to assess toxicity, and some of them with the rarer toxicity of muscle inflammation that can occur in the elevation in CPK levels as well. But that we do only based on clinical symptomatology.
Exactly. And I've relied on sunitinib. Those side effects tend to come later, and so I feel more comfortable with vismodegib. I think I would always bring people back 4 to 6 weeks as well. Well, he missed his next appointment, and he said he was getting better, but clearly I don't think this is better. Now the plaque is the whole lower eyelid, ulcerated and fixed to the bone. The MRI now shows there's clear subcutaneous muscle involvement. And again, surgery, certainly possible, but exoneration has entered into the discussion. And so after this discussion, we shifted that maybe unsure how well he did on hedgehog inhibitor. Was he truly taking it? But we made the decision to offer systemic immunotherapy. But he actually said, I want to do surgery now. I'm tired with therapy and I want to do surgery. But unsurprisingly, did not return for that surgical plan. And it brings up the case that we've discussed, that what the dermatologists are saying is a wide variety of tumors, and 99% of the time, we're doing non-systemic therapy cases. You can do, and what I like to say is, you can almost treat most basal cells with anything, and they're going to do well because they are, as I say, the cavity of the skin. They don't need root canals; they're cavities, and we got to get them filled. But Not every cavity is filled right when you see your dentist, and sometimes you don't even realize you had a cavity. And that stratification of lower and higher risk relates to recurrence, and the NCCN nicely helps us divide those two up. But sometimes I find it challenging because the high-risk ones don't have the same impact necessarily. A poorly defined border is not necessarily the same as a 2-centimeter or larger tumor on the head and neck area. But this is useful for us, and I think Nikhil, and I won't repeat what we talked about with staging, but most dermatologists, we're not thinking like oncologists. We're not staging. We're thinking about we have 10 minutes for a visit and we got a high volume practice. Is this something that I can treat easily, or is this something I need to involve somebody else for? And until the Brigham and Women's alternative staging system for basal cell came up, we didn't have a good idea of how to categorize those. Well, now we feel a little bit better based on this study by Morgan et al. And the group out of Boston, showing the features that are really associated with poor outcomes. And those are few: tumor diameters greater than 4 centimeters, head and neck location, invasion beyond the fat. And that rarely occurs. So I think the vast majority of tumors we define as T1. But our colleagues in surgical oncology, head and neck, and so it's important for everybody to have that same lingua franca, that same language that we use. AJCC is key, but the shortcoming, of course, that AJCC is for basal cell. It's the same system as squamous cell, but the two tumors are quite different. And a T3 tumor in basal cell is not the same as the T3 tumor in a squamous cell carcinoma. So I prefer the basal cell to help us figure out, at least for the dermatologists or the medical oncologists, when they're going to be involved in those T2 tumors, because this study is showing that those tumors, not recurrence, that's just an impact, but that metastases and death significantly goes up. Treatment guidelines from the dermatologist standpoint, you can see this is a dense slide because, as I said, you can do almost anything with the low-risk tumor and likely have a good outcome. The question is, what is a sufficient outcome to that patient? And I've been surprised at what patients find acceptable. 70%, 80%, 90% or higher can change or be different between older, younger patients and the location. And I find myself using more and more non-surgical therapies in the younger patients because the field has moved, that we feel comfortable if something comes back, we can take care of it with a complete margin analysis surgery if necessary. Not everything needs surgery straight, just up front. When surgery is performed, I'm a biased micrographic surgeon. Looking at the whole margin intuitively makes sense that you're going to have better outcomes, and I think we have data to support that. But that does not mean that everything needs micrographic surgery. I think that's actually a shortcoming of our field, that everything we reach for micrographic surgery, and certainly if we overdo it, we're going to have reimbursement and other limitations. And so being thoughtful around what to do for what tumors. I won't belabor the advanced BCC components since Sue gave us a nice overview of those treatment options, but certainly the multidisciplinary approach is important for the dermatologist and what we think about. And I'll lastly say, before we get into this case, topical therapy is becoming more and more. There's some exciting topical agents, immunotherapy, imiquimod, that's underutilized, but some other ones that are being developed that the dermatologist is going to be using more and more. And I think the medical oncologist, as Sue said, I play a medical oncologist on TV, and she'll be reaching for topicals to play a dermatologist on TV and be able to treat tumors. And that certainly will be the future for our community providers who may have difficulty getting access to a dermatologist to be comfortable with some of those topicals, because they can be utilized very effectively for those low-risk tumors. All right, let's shift gears and talk about a squamous cell carcinoma. And this is the pretty typical pattern for a high risk from a Mohs surgeon standpoint, not the high risk that Nikhil and we talked about with CPOS, which what I like to call is the locally advanced high risk or very high risk tumors. But high risk in the sense that this is a patient who's had multiple non-melanoma skin cancers, and clearly there's some scarring there. She can't give me the exact history, and she says a long time ago, 15 years ago, doctor, 20 years, I had a head and neck surgeon cut a lesion out, and they told me I needed some radiation, but I didn't go for longer than a few weeks, and I can't recall, but I had some treatment in this area. And now 10, 15 years has gone by, and she's developed this about a little over 2 centimeter, 2.2 centimeter nodule right at the edge of that radiated area, that scar. And it's firm and it's indurated. And I feel like dermatologists, sometimes we get caught up between what stage is it? Is it high risk? Sometimes I just like to say it's bad. It's bad. You know it's bad when you walk in the door and you're worried about what's going to happen. But here's the challenge. And I think the challenge is for dermatologists and medical oncologists. We're seeing, maybe my clinic, this was my Friday clinic with consults today, I saw 40 of these. And it's hard to pick out of the 40, 38 of them will do really well. Which of those two? And we talked a little bit around the staging. Well, I'll say just here, we decided to do surgery for this patient. It's a resectable lesion. I think just to go back, anybody opt for not surgery in this scenario if the patient was amenable for surgery? I kind of wish I may not have done surgery, to be honest.
What was the pathology on the new biopsy? Was it a poorly differentiated tumor?
It's a moderate to poor differentiated tumor, yeah. Recurrent 2.2. And so, as you would say, Nikhil, I think a dermatologist would not be thinking about staging, but we're looking at a T2B tumor that has recurred, which we already know has a higher recurrence rate.
Vishal, I have a quick question. Did you get any imaging, or was it mobile on exam?
No, so it was mobile, but felt really deeply invasive. We did get imaging with no muscle involvement, no lymphadenopathy, which I left out. But that is a key point that I think dermatologists either sometimes over-image on the low-risk tumors and underutilize in tumors where we should consider that. Evan, any thoughts?
Since she had a prior course of radiation therapy, I think that was part of your history, right?
Yeah.
Generally advise against doing another course of radiation therapy in an immediately adjacent tissue like this unless there were no other good options. So.
And that's exactly what our concern was not. And she just wanted it gone and felt like we could provide complete margin assessment, which we did. We got clear margins, but this took 3 stages and it was only invasive deep. The primary margin, which sometimes I like to say, especially for our medical oncologists and surgical oncology, is that when you think of Mohs surgery, micrographic surgery, they say, well, you're going to take small margins and you're going to take a small margin just to preserve tissue. No, we want to have complete margin analysis. And that's why it's so good for high-risk tumors. We took a 1 centimeter margin because we knew this tumor was high risk by those features. And that peripheral margin was clear, but the deep margin was invasive to the second layer of muscle. What you can see there essentially is we've cut through muscle and we're seeing different tendons and muscle aspects of the lower layer of the muscle of the face and requiring resection of a large caliber nerve. The marginal mandibular nerve had been resected. So now this is where we say, now what? What do you do? That's where we call Evan and say, you said no more radiation, Evan, but there's a large nerve. Or I say, Nikhil and Soo, and this was, by the way, 2000. I think this case I highlighted was because it was pre-C-post and pre-neoadjuvant. This was actually a patient we were thinking about enrolling in C-post after we found this out. So we didn't have cemiplimab, but I open it up to you all and say, what would you do now? Evan?
Well, one of the first questions is there enough perineural invasion that you're concerned about perineural spread? So does this patient need an MRI? So I think this is a difficult question. We tend to err on the side of getting MRIs for patients with extensive perineural invasion in the head and neck. If there is not perineural spread on the MRI, I still probably would not offer this patient postoperative radiation therapy unless there was a really compelling reason to, because
I agree with you.
Yeah, the risks of reirradiation are real and potentially long-term. The radiation therapy regimens that are chosen because they almost never give long-term side effects that last forever and cause a huge amount of problems in a first course of radiation therapy. But with a second course of radiation therapy, that's not always true. So I would generally say no, because there's a chance that this patient has been cured surgically, and then I'll let the medical oncology colleagues comment on C-post and adjuvant IO.
Yeah, I'll just say that was exactly our thinking. I mean, there's pretty robust literature now that a clear margin when using micrographic surgical standards, complete margin analysis, even with perineural invasion, has a durable clearance rate that you can rely on. And that's even though there was large caliber PNI, named nerve PNI, had a clear margin and felt really confident with our surgical margin. So we did not, we discussed briefly, but did not offer radiation therapy for this patient. We didn't have the option for systemic therapy, but Nikhil, Soo, would either of you offer an adjuvant systemic therapy in this case?
We'll let the lady go first.
I think it would be reasonable to also just watch the patient. You said she has microscopic large caliber?
She had the marginal mandibular nerve was sacrificed due to get the third stage margin. So it fits C-post criteria by that one.
Yeah, I would. But the fact that you won't be offering radiation, so I think these one of the rare cases that I have offered adjuvant cemiplimab without radiation, but having a careful discussion with the patient that the study was not designed that way, but highlighting the high risk features of this specific patient and the reason why, radiation was not recommended. But, not everyone is able to, willing to take the risk of PD-1. And so I think also just watching is reasonable, but then you would, the risk of perineural spread in the future is quite high.
Nikhil, your thoughts?
I would offer adjuvant systemic therapy here with cemiplimab for two reasons. One is this is recurrent disease. It came back in a prior location with prior radiotherapy. We've tended to notice that those patients do have more aggressive biology in terms of their disease. And based on the CPOS criteria of recurrent disease, poorly differentiated tumor, and greater than 2 centimeters, this patient met all of those criteria, plus the description of the gross involvement of the margin mandibular nerve that required sacrifice. I think this patient is clearly in that high-risk category. If you look at the FDA approval, it's sort of a very generic high-risk CSCC. It doesn't specifically state that we need to, stringently go by the book of the criteria.
I think the label says bad CSCC. That's all it says.
Yep.
Just bad CSCC.
So I think in this case, I would definitely offer it. But if the patient elects to choose observation, it's not unreasonable. But when they pose that question, what would you do? If I was your uncle, aunt, brother, sister, so on and so forth, I would say I would certainly consider this quite seriously.
Yeah. And we didn't have that option at the time, but now in hindsight, I would have also certainly considered that as well. But I think from the dermatologist standpoint, sometimes we get these, maybe not as extensive that these, maybe they have PNI 0.1, what Evan talked about, where we're thinking about referring to radiation. You see a lot of these tumors, they may have Brigham Women's T2B. And despite the presence of these NCCN guidelines with risk stratification features, the reality is many of us, not because we don't want to, but the community practitioners, they see so many tumors, and it's difficult to know what risk factors matter more. Is there a combination of risk factors that we worry about? Is it just one? And these guidelines are not necessarily correlated with a recommendation for treatment, and that is a shortcoming. I think that they're clear outline like we do for melanoma, for Merkel cell, and squamous cell is developing, it's improving, but we have definitely been lagging that side. I'll skip over the staging system since Nikhil talked about that and just highlight the fact that the vast majority of those, as we said, of bad outcomes come in the T2 group, and many medical oncologists are familiar with AJCC, but I urge our dermatologists, if anybody's living, to be familiar with AJCC, even if you use Brigham and Women's, because it's important to communicate the risk to your colleagues that you are then referring to. It's these poorly differentiated T2 tumors that I worry about the most. That's probably what we're missing in AJCC that gets caught in Brigham and Women's. The group out of Spain tried to refine AJCC, but it's become quite cumbersome to know all these different risk factors. And so it's just not commonly utilized, documented. Papers have looked at which staging system is better. I would say if you stage, that's probably the first step that would make you a good dermatologist or a dermato-oncologist. And if you communicate that. I don't have the slide here, but I think what would be relevant to our audience is gene expression profiling. It's become a really hot topic. It's been pushed as the answer for answering saving, but I have some serious reservations about utilizing that because of the 5 million plus cases we have. And based on the high risk features, we're talking about testing an innumerable number of cases that I only have utilized gene expression profiling for the one available test that's out there. In a patient like this, I actually think it might be useful where we're trying to figure out, should we offer adjuvant therapy? And if we can test the tumor and say, you appear to look like a low risk profile and push you towards observation, that data point to me has been helpful. But I have not utilized it to escalate care and to figure out which patients I should treat more aggressively. Maybe those where I just want to de-escalate. Any thoughts on gene expression profiling from your standpoints?
No, I agree with your sentiment, Vishal. I think, and the lack of prospective data or validation of that test, to me, certainly limits its general applicability. And for the very fact that you mentioned that we see so many of these cases from an incidence standpoint, I would not want a patient to have the test be labeled high risk and then come to us saying, well, we need systemic therapy because I was told I was high risk. Unfortunately, I do see that.
Yeah.
I still think the systemic methodology that should be followed through multi-D involvement, surgeon, radiation oncologist, medical oncologist, still in my mind should rule supreme in terms of really trying to help patient navigate through this pathway.
Yeah. And I like to tell our dermatology colleagues that if you're thinking about this, ask before you order it. Or our medical oncology colleagues can tell their colleagues they get referrals from, let's chat before ordering this test so that we can decide, let the medical oncologist or surgical oncologist offer that and make that, or radiation oncologist make that decision. As there is some data that it helps to stratify who are radiation responders versus not, and I've utilized it for that as well. Just a note about host risk factors. We talked a little bit about different risk features, and the big one being immunosuppression is a host risk factor that is underestimated in terms of, or not underestimated, but certainly that tumors, we can underestimate the aggressiveness of the tumor because immunosuppression is difficult to measure. But I wanted to and we know that they are associated with poor outcomes, but there's been some recent evidence. I mean, we've come a long way with immunosuppression. Immunosuppressive regimens have changed for transplant patients. The impact of the organ and the volume of immunosuppression that they have to take has changed over the last 10 years, moving to an mTOR inhibitor-focused regimen instead of calcineurin. And it's interesting to know because dermatologists oftentimes label everybody who's immunosuppressed, whether you're lupus, HIV, or transplant patient, as high risk, but not all immunosuppression is the same. And this was a nice study that really highlighted that there is maybe a minimal risk with tacrolimus, mycophenolate, everolimus, sirolimus, cyclosporin with just broad immunosuppression use. That azathioprine probably had the highest risk. And then if we look at the subgroups, the transplant patients, we're doing a lot better with them. It's actually the patients, you can see here, HIV/AIDS, not really a hazard ratio that's concerning, but it's maybe the chronic lymphocytic leukemia, the ones that have lymphoproliferative disorders that are the worst of the worst performers that I worry about more than our transplant patients. And those are some that we can still think about using systemic immunotherapy. I'm going to stop on this slide and say that the risk definitions that I think are useful relate to treatment as a dermatologist. Those that are low risk for disease-specific poor outcomes. These are the majority of tumors. And as a dermatologist, I think they're suitable for a variety of treatments. You got to figure out, is scraping and burning it, is scooping it out, is cutting it out, is radiating it or putting a cream on it makes sense. I think all of them are great. And they can be discussed with the appropriate follow-up and risk discussion. The moderate, or what I call increased risk, are the ones where we want to do complete margin analysis. These are the ones that we will come back and have a substantially higher rate. And those calculators, those nomograms we utilize, I put this risk about in the 10 to 20% range of local recurrence. That is substantial enough that complete margin can reduce that by half or more. High risk is something that needs something beyond surgery alone, in my mind, whether that's adjuvant radiation, systemic therapy. There's a high risk of nodal metastases. And the locally advanced is that already had the horses out of the barn. You need multidisciplinary care, multimodal therapy to get a cure. And so on that note, I'll stop there. I'll pause there and open it up to my colleagues and back to you, Neil.
Vishal, I had a quick question.
Go ahead.
Can you tell us what happened to your second patient?
Second patient had a skin graft placed, did not have radiation therapy. I think she passed away from other causes, maybe a little under 2 years from that, but did not have a recurrence in that 2 years time period. And maybe one last thought for our medical oncology listeners is that while we're on systemic therapy, these patients, I think we all see that they still make a lot of new low-risk tumors. And so the dermatologist still needs to be involved, and that communication with the dermatologist and back and forth to accurately risk assess will continue even though somebody stays on systemic therapies. I still have to cut out small tumors or scoop them out while they're getting cemiplimab or pembrolizumab, and we still have work to do to figure out why that's occurring and what's the best way to treat those.
I have to second that thought from Vishal, absolutely, because when we see these patients in medical oncology, they feel that we're seeing them every month for their systemic therapy. So by default, we are also their dermatologists, and quite frankly, we're not. We certainly stress that they have to maintain follow-up with their dermatologist, and after some of the excellent results we get with systemic therapy or multi-D treatment, these patients have a noticeable higher risk of developing new skin primaries as well.
This concludes our program. Special thanks to the faculty, and thank you for listening. This is Dr. Neil Love for Striving for Consensus, optimizing the multidisciplinary management of non-melanoma skin cancer.